Hello, and welcome everyone. This is Dave Roth. I'm the Chief Marketing Officer at AvaSure, and I'd like to welcome you personally to the 6th annual AvaSure Symposium. First up, I'm going to cover some housekeeping for the day. Please note that all sessions are being recorded, and they will be available after today. This is day 2, so if you missed day 1, also look for those links. Everything will be recorded, and an email will go out a few days afterwards so that you can listen in on any of the sessions. Next up is questions and answers. Please note we're using a platform that you're logged into that will host Q&A. There's also a lobby area with some things that you can download for other information. Please post your Q&A during each session, and then go ahead and vote on each of the questions and answers. If there are particular questions that you'd like us to prioritize, we will cover questions and answers at the end of each panel presentation. And last up, there will be a survey at the end of the day. So after we get through all of our topics, we'll end around 4 p.m. Eastern Time. A survey will be posted, and we'd like your responses in terms of how we did, things we could improve on, topics we should cover, so on and so forth. That helps us to provide lots of great information going forward. All right, before we get started with our first presentation, I wanted to just mention a few things. Yesterday, we talked about our Ava Prize, highlighting some best practice examples. We will be offering up a presentation on Ava Prize winners before the end of the year. Normally we do it during the symposium. We've had a lot of content that we wanted to cover, and we want to make sure to put special focus on that. So please stay tuned and look for that. Also, we got a lot of questions in terms of the virtual nature of this symposium. We absolutely want to do this in person. Right now we're looking at an in-person AvaSure Symposium for the middle of next year. And so please stay tuned on that, and we'll send out some more information. And it's wonderful connecting all together in this type of format, but we're also looking forward to getting back together like we have done in the past. All right, next up, wanted to talk about our panel sessions for the day. So we have 3 different panel discussions. In between those discussions, we're going to have an AvaSure Spotlight moment where we'll interview one or more AvaSure employees. We continue to grow, and we continue to have valuable information and different roles that we network together with all of you, and want to do that along the way. But in terms of our panel sessions, we have 3 of them today. One on change management, one on centralized monitoring, and the last one will be a fireside chat with our CEO as well as Gerry Lewis. So first of all, I wanted to talk about the change management. Our first session is called Creating Awareness, Confidence, and Excitement. This is about managing change, and this is about being change agents as part of your AvaSure deployment. We heard yesterday the importance of managing change. Nothing's more important than creating trust and education, working with your teams. We heard from Juliet and Inye from North Texas VA in terms of the success that relied on her ability to manage through some of that change. This is more than just a technology. This is more than just information. This is about people and teams working together. And so part of that change is something that we help with. About 15% of our staff here are nurses. We understand your workflows. We come to understand your environment, and we work with you to share best practices and manage through that change. That is absolutely critical, and that's something that we pride ourselves on. So our first session is going to talk about change management and share some tips and advice from that panel discussion. Next up is centralized monitoring. The topic is optimizing labor across an entire health system. Once again, this is something that we really focus on as an organization. You'll hear a term, camera in every room. We think of that as more than that. We think of that as a patient monitor in every room, a virtual nurse in every room. This is more than just a technology. This is more than just a camera. What we offer is scalability. We call that a hub and spoke model. Actually, someone celebrated a hub-iversary yesterday in terms of their 4-year deployment. But our centralized monitoring, we make key investments in that technology. So for larger organizations and systems that need to scale seamlessly up to 500 devices per server, that streaming is reliable, that our uptime is 99.9 and so on percent uptime and reliable, we've designed to that specific scale. We're going to talk about how we optimize labor across an entire health system with that particular technology and framework. Last up, we'll close with a leadership fireside chat with our own CEO, Adam McMullin, and Gerry Lewis, CIO for U.S. Radiology Specialists. Prior to his role with U.S. Radiology, Gerry most recently served as SVP and CIO at Ascension Health. So they're going to share a fireside chat. They've recently had some good car time to catch up and summarize that for us in terms of where technology plays a role in our future. And so you're going to find a lot of great content in each of these sessions. Again, all the sessions from yesterday are recorded. You'll be able to go and play those back. All right, one more housekeeping session, which is to talk a little bit about our form factors and our product. In yesterday's panel discussions, a lot was talked about in terms of our devices. We've been making big investments in terms of all of our different form factors, and so that everyone is aware, and if there's a slide on this, I can't really tell, but we offer an array of devices and hardware as an organization. Some are one-way and two-way remote and mobile devices. There are ceiling units, and so in yesterday's panel discussion, camera in every room was described as a ceiling unit. The ceiling unit fits into a tile, hardwired, but we also have something which was highlighted yesterday called our Guardian Access device. And our Guardian Access device, I'm going to grab it real quick. That's this device right here. Our Guardian Access device is also designed for camera in every room. This is wall-mounted, hooks via HDMI to a TV in each room, and is very helpful with all modes of communication. If you're used to our devices and seeing some are quite tall, obviously the ceiling unit is designed for the ceiling. This is specifically designed to be fully functional as well. High sensitivity microphones so you can hear patients who might still not be able to vocalize very loud, while having a speaker that is can be very loud depending on what the room environment is, especially for those who might be hard of hearing. So not going to get into all the specifics of this. If you want one of our monthly discussions, we've been rolling out monthly webinars to our customers. This is all available on social media and on our website. One of them covers our different hardware options, and I want to make sure that we got all of that out there. Again, we've got the mobile units, we've got the ceiling units, we've got the Guardian Access devices, and we'll find out more on all of that. So, without further ado, on to our first panel discussion. Our first session of the day, Change Agents, Creating Awareness, Confidence, and Excitement. You're sure to take away some great tips. I will now pass it on to our moderator, AvaSure Manager of Clinical Implementation Services, Wendy Popma-Breen. Come on up, Wendy.
Thank you. Good afternoon, everyone, and welcome to our change management session. I am very excited and I'm very honored to have these three individuals here today to talk to you about their amazing program at Carilion Clinics Hospitals. And so with that said, hello. Let's go ahead and get started. Let's first start with having you all introduce yourselves and maybe your title or role that you have for your telesitter program.
I am Shannon Robertson, and I'm one of the unit directors for virtual care operations.
I'm Megan Alexander. I am a nurse in the Carilion Transfer Center, and I'm getting my MSN and have been studying the virtual care operations.
My name is Jason. I am not a nurse. I'm a paramedic, and I'm the other unit director for this department.
Well, thank you all for being here to share your amazing program with all of our audience today. I'm not sure who wants to start with this question, but maybe just give an overview of all the hospitals that you are deployed in, maybe the number of devices, and maybe just a little bit about your program.
Sure. Shannon has been here just a little longer than I have. She's been here a year, August, and I came in May. So we were not actually here during the inception of this idea and the implementation of the program. So we came shortly after. So we were not, we can't really speak to the thought process behind going through the program. But currently we have 72 devices, and we have a large like base hospital, which is a level 1 trauma center.
Mm-hmm.
It's 700 or 800 bed hospital. Yes. And then we have smaller community hospitals and a couple critical access hospitals in our system. And we have smaller number of devices at each of those hospitals that they can use for inpatient. And we're also in the ERs in all of those facilities as well.
You know, we talk about change management, you know, for implementing a new program, but you guys really got like put right into this change management now. You were brand new when you walked into a program that had already started and kind of developed and designed for things that they wanted to monitor before you took over. So tell me a little bit about how you learned all this after something's already gone live. There's a lot to know about this program, right? You got your software, you've got your processes and your policies and, well, the dashboard and the data and the ORNA.
Well, I'll be honest with you, we are still learning. We are trying to get a hold of the data, and that's why Megan is here with us. She can speak to the data that she's been studying. But one of the things we found is we didn't really have a good grasp on our numbers and our fall prevention numbers and all of that. And the other thing we noticed is we had made this large purchase. We started with 48, mm-hmm. and then we went up to 72. And we noticed that even with the implementation of ERs, even with the implementation in the spoke hospitals, the community hospitals, our volume just was not there. And so we had to kind of get a handle on, you know, yes, we've had this big implementation, all the messaging has been put out originally, but how do we become a useful and an indispensable service to our system?
So it sounds like once you guys took over this program, you identified early on one of the main things to be addressed was the utilization.
Yes.
So what are some of the things that you did or are doing to improve that now?
Well, the biggest thing is I think in anything you do, you're going to be your biggest advocate. So if you're not engaged and involved and out there selling yourself, nobody's going to sell you for you. So together we have met with CAPS, we have met with CORE and their nurses. These are all nursing teams in the hospital that have senior management on down to unit director level stuff. So we put together some PowerPoints. We met with all these groups, told them about our services, explained how they can be used, explained the benefits of them being used. We have met with unit directors. Our units are developed into pods, so different units kind of develop up into a pod. We've met with those different pod directors. We've gone down to the individual unit level directors. The other thing that we thought would be a good idea is most units, nursing units, they round every morning, and mm-hmm. they round on a unit level, and then that bumps up into a hospital-wide daily huddle is what we call it. And that has to do with throughput. So what better way for them to identify people, and we made sure they had our inclusion exclusion criteria, but what better way for the charge people and the unit directors as they're rounding to identify people that are prime candidates for our service. So they can then elevate that up during huddle and let us know, you know, and we can contact them and tell them and try to work with them to get on our service. The other thing we did is we have a couple people that are really good car salesmen. And we basically started off, and they basically cold call people. We are able to figure out through teletracking and the huddle numbers where the needs are for one-to-one sitters, and they pretty much sit around and call and say, hey, how you doing? We'd love to talk to you about so-and-so patient and find out some information and see if you can use our service. And some people are receptive to that. Some people are not so receptive to that. And they ask questions like, what can I say to get you off the phone? And, but that is actually done really well, surprisingly enough. And we make sure they understand about the trial period. We make sure they understand about, how this can alleviate them from having a staff member in just one room that they can use for numerous rooms if we have a camera in there.
I'm really glad that you shared that story about the cold calling, because you told me that yesterday and I thought that was great. So are those your monitor staff or the virtual observers that are actually doing those cold calling? So they're the ones, huh?
Yes.
That's amazing. So Jason, what I'm hearing too is that, again, I think Carillion went live in 2021. You guys came in August of 2022, right? And you're still going back to places and still going to leadership and still going to management to really continue to, bring awareness to your program.
Correct.
Change doesn't end, does it? It's
No,
constant.
it doesn't. You have, if you don't keep yourself on the forefront of people's minds, they're going to forget you. The downside to being a remote service is you're just that. You're out of sight and out of mind.
Mm-hmm.
If you let yourself fall into that. You're the voice on the other end of the phone from, for this. And so that's kind of a pitfall. So we as management and pushers of the service have to be engaged in finding different ways to utilize the cameras that we're doing. We just went into the ERs. We've actually started now to put our cameras in common areas. So we have one of our floors is a geriatric floor that is a high utilizer, our highest utilizer actually. But because of staffing issues, one of the things they do is convalesce patients around the nursing station during the day so they can put a patient care tech at the nursing station and watch 4 or 5 different patients while nursing staff is doing other stuff. So we decided to put 2 additional cameras in the common area to help be a second set of eyes for them. We're going to do that same kind of concept at another hospital. We're going to do the same concept in our ER waiting room because, flu and cold and all that's coming.
Behavioral health. We're looking into doing it there as well.
So you basically you took over the program, like you were saying, and utilization was a big driver for you. So you basically went back to the drawing board, thought about new use cases, brought these cameras to the ERs. Now you're looking at other places to put them in as well to improve that utilization. You went back to your leadership. What do you think with these changes now that you've implemented? What are some of the obstacles, if any, are you facing from implementing these new reasons to use it or these new places to use them in?
Those inpatient staff, some of the nurses do not trust us, so to speak. They have a hard time feeling like somebody through a camera that's watching other patients can prevent their patients from climbing or falling out of bed. So just building their trust is improving to them that we can do this.
Trust is a big one. You're right, between the monitor staff and the nursing staff, those boots on the ground nurses. So what are you doing to help build that trust? Are you doing anything differently or having them are you having them go and meet the nurses or improve the communication? I'm not sure, so maybe you could share a little bit on that.
We offer, whenever we're having those conversations with the inpatient staff, we ask them to come over and shadow and see what we do and see our processes. And then whenever we have new staff, we are trying to get them over in the hospital so they can see that side of things too. So each of us can see what each other are doing.
Because that does become a little difficult, doesn't it? When you have this hub and you have all these spoke sites, they actually can't always see what's going on. So I like that you're having them or inviting them to come and see what really goes on at the monitoring station. Have you found that that's helped?
Yes.
I think so. I think, and and sometimes it takes a little push for people to use you, and they have some reservations. And once they see that you're helping and kind of freeing them up, then I think I've noticed that the cold calling, they're now expecting us to call, and they're much quicker about using the service and say, yeah, I was going to call you about this anyway. And so I think they're getting more used to hearing from us, knowing we're there. They know we're going to bug them about it, so they might as well just go ahead and do it anyway. So I think it's working. Yeah. One of the barriers that we run into with this as well, this is, since COVID, a lot of things have gone virtual. Mm-hmm. So one of the things that we're running into is you're breaking into new grounds where there's no previous history for anybody to go off of as to whether it works well, does it work good, what different groups do you have to get okay from. So when you're talking about behavioral health, that's a whole different set of accrediting bodies that you have to deal with when you're then inpatient folks. So that's kind of where we were hoping to break into. We can do common areas, but we still have not figured out yet, how do we put cameras in behavioral health into private rooms? Because then you get into consent issues that you don't have, and privacy issues that you may not have inside the hospital. So we think we can pretty well do behavioral health group sessions for staff safety. To the way the building is designed, there's some blind spots would be a good place to have cameras to keep patients from exiting. They do have security cameras, but nobody's watching those 24/7 like what we are. Mm-hmm. So there's a lot of opportunity out there to use these for staff safety as well.
Oh, that makes me extremely happy. ER nurse back in my day, and workplace violence from patients to nurses is underreported. We know that. So thank you for looking at that, continuing to, improve upon that. That's amazing. And I'm sure the staff will appreciate that. So again, back to some more change management. Like we're not part of this when your leadership or the stakeholders, endorse this new program, this change. And we know that needs to continue, right? They need to continue expressing the change, modeling the change, enforcing the change. What about your hospital's culture? How does it contribute to your success now as you keep evolving your program?
How does
the culture in general, like overall culture of change and change management, how is that working for you with the leadership and the stakeholders that were originally maybe involved in this, that brought this program, this AvaSure program, into your system?
Well, I'll be honest with you, I don't even know who they are, to be honest with you. But I think trust is the biggest thing. Mm-hmm. If you can build that culture of trust between us and the staff. And it's one of the things I will tell you that I was really amazed about. You would think that the folks watching these cameras, they're just watching a camera. They're not really vested in anything. They're just watching to make sure a patient doesn't really do anything. One of the things I quickly found out was the folks that are watching this camera, they understand more about these patients probably than even some of the nursing staff do. They're watching them 24/7. Mm-hmm. I've had folks tell me routines. They know where they're getting to go next, what their daily routine is. They talk to the patients every day. They've heard family stories from the patients every day. So it's amazing that the people watching these cameras have a vested interest in the safety of these patients. And I think that comes through when they're talking to the staff at the hospital about their patients. So I think that's one thing that helps build that culture of trust between our techs and the staff.
I agree. It's a very intimate relationship that the monitor staff have with that patient. You're absolutely right. They are eyes on all the time. So that is a trust thing, and you're right. That has to hopefully your nurses are seeing that and they're hearing that, and that's going to continue. I know you have some great data to actually share, Megan. So I want to talk a little bit about that because and let's first talk about the metrics that you are looking at to improve upon your ongoing evaluation of your telesitter program. You know, I looked at your data today, and you do watch a lot of patients for falls. So why don't you share some of the information and some of the data that you have for your program?
Without actually giving out, you know, our numbers for falls, I've looked at it a couple years before implementation on our inpatient units, and up until, you know, this point.
Mm-hmm.
And we are trending downward pretty significantly. I think that Carillion will be very happy to see it all. I think we peaked in 2020, probably like a lot of hospital systems.
Yeah.
In the height of COVID. So I was happy to share that with everyone after reviewing it. I did track our ER for our biggest facility, Roanoke Memorial. I tracked the data for falls in there too. But I think the implementation is still in the infancy there, that you can't see a significant change yet because it was just in September.
Mhm.
So I'm anxious to see how that turns out. I'll probably look at that at the end of the year, just out of curiosity. But that's what I found so far.
Well, I appreciate you sharing with me. Sorry, audience. It was impressive, so just know that. And it's great, right? And hopefully now, once you are able to share that with, you know, your leadership, how are you going to do that? How are you going to get this information out to the managers and the frontline staff? Because again, I think this is another opportunity for them to see that this is working.
One of the big things that we found is, you know, if I have 72 cameras and my utilization is 20 across the system, then it behooves me to try to figure out a way to show the bosses bang for the buck. You know, nobody wants to buy 72 cameras and you only use 20 of them. So that was one fold in our utilization. The other way to show that this was a worthwhile purchase, what I just found out the other day, you can actually put a dollar value on each patient that falls, which you start talking about getting into somebody's wallet, people start paying attention. And if you talk about the money you're saving them in their wallet, they pay more attention to what you're doing. So if I'm correct, and please correct me, I think it's $3,000 for every fall prevented, something like that. I think is the term, is the dollar value I heard, and it's more than that for any fall with an injury.
Mm-hmm.
That, you know, so if you have so if you look at your falls prevention and then you have an X dollar value, then you can show, you know, a tangible amount of money that we have saved the facility on having to deal with the consequences of a patient that fell, which,
Absolutely.
you know, usually perks people's ears up.
Yeah, it would perk mine up too. So what about sitter reduction? Megan, have you looked at that? Or are you guys just looking right now at falls?
Right now, I have just been looking at the falls rates. I am interested in eventually digging through the cost reduction and along with the sitter reduction cost rates and seeing where we stand.
And another thing that you have done as well, Jason, you have developed dashboards for your quality department. Are they working with AvaSure right now, correct?
Yes, I actually we have two folks that are two of our high performers on the telesitter side, and we wanted to kind of get a handle. You know, data's only good the data out is only as good as what you put in. And what we noticed was that we were over documenting, so we were over representing our fall prevention stuff. So we wanted to kind of get a handle on that so that we could. So when folks like Megan come to study our data, they're actually putting out good information because of what we're putting in. So we have two high performers that are actually going to meet with a lady from your company and develop a dashboard for us. And one of our actual 22-23 department goals is to reduce our over documentation by 10% over the year, through the use of this dashboard, through the use of education, through the use of quality assurance and looking at documentation. So that, yes, I'm very excited to see what happens with that. And who knows where that's going to lead once we develop those dashboards.
You know, and another thing that I noticed in your data, your stat alarm response times for your nurses is quite low. It's around, I mean, it's 15 seconds for when your monitor staff activate that stat alarm, and those nurses, and this was across all the hospitals.
So every day at 11:30, we do a daily huddle through all of the Roman Memorial, and then earlier in the day, we do huddles for the outside facility hospitals, and we give them the numbers of the response times, the stat alarms. So everyone is seeing those numbers, so it's looked at.
So
Not to
you're,
mention,
oh, good.
heard the volume of that thing?
What's that?
She didn't hear you.
What did you say, Jason?
Heard the volume of those alarms, you're going to come running.
Oh. But that's great that you're sharing, like I said, you're sharing this information because it's working. You're getting that out to the, staff at the hospitals. And have you been communicating? Do you know if they're communicating to the frontline staff, those nurses that are actually running into the room, how amazing they're doing?
I would like to hope so, but unfortunately, I can't answer that question.
Okay, well, we need to do that. The other thing your staff is doing that, again, I was blown away with is the verbal communications. Your staff's verbal touches, verbal, communication, when they're talking to that patient is extremely high per patient day. How do you get your staff to be engaged regularly with these patients?
I think through education was the first part. I think we had some education where, hey, you should be engaging with these folks on a regular basis because, I mean, I have a parent that has dementia, and before I came to work here, I had they had in a hospital admission, and I can remember coming in and seeing this 9-foot tall robot looking thing standing in the corner of the room. So I can imagine for someone who has dementia or some sort of cognitive disability, it's kind of an intimidating looking thing in the room. So we want them to talk to the patient, find out how they're going, engage them. So they're not just the voice coming out of the ceiling. I think the patients are much more apt to react and comply if they've been conversing with that as if it's a person all along. To the patient, and a lot of it they do on their own. They just seem to enjoy interacting with the people, and that's how they develop those relationships. And usually what they will do is if they work 3 12-hour shifts in a week. So if they come in on a Monday and work 12 hours, they want the same patients back because they have built that rapport. They understand that continuity of care, and it works. I mean, it works fantastically. So.
Well, yeah, we do that with nursing, right?
Yeah.
We want our same patients back. So what does it look like for your staff at shift change, for the monitor staff? Do they sit down, get report from the other monitor staff, and automatically right away introduce themselves to that patient?
We have asked them to, yes. So they sit, the tech that's going off will stay there and obviously watch the patients, but then they'll go through each patient and tell them how their day was and what they've been doing. And then the next staff will step in, and we've asked them to introduce and, hey, I'm going to be your monitor tech tonight, or introduce them by name, whatever, and say, hey, I'm back again tonight. So we've asked for them to, yes.
Oh, I like that. I'm glad they're doing that too. It's so important. What about when the next shift comes on, do they sign off with that patient then? Do they let them know they're leaving?
Some of them do, especially we had a lady, she was on, I guess, 10 or 11 months we had her. And I mean, they would, bye Lillian, we'll see you tomorrow. It was a family member. So.
Was that at one of the rehab facilities or a rehab?
No, she was actually inpatient.
Wow.
Yeah.
We've had several patients that they've had for 200 plus days, almost, we had one fellow that was there for almost 300 days. He wore an Oscar the Grouch hat all the time. So every day when I came in, I'd go over there and say, how's Oscar? and they knew his routine, and he had his little Oscar the Grouch hat on. He laid the bed on. It was kind of funny, but yeah, they checked on Oscar, every few hours and asked him how he was doing.
Well, whatever your staff's doing, tell them to keep it up because, again, looking at the data just right there, hopefully this, again, will improve the buy-in from nursing staff, that trust building, because they're constantly communicating with that patient. We know that's extremely important.
Well, the other thing we found is, the other thing they have done kind of on their own, and we have emphasized, is they don't work in silos. So, and what I mean by that, so the screens are set up to hold 16 patients. What we have found is that's probably a little much for one person to watch. We think the sweet spot is somewhere in the 8 to 10 range per tech. And as well as I do, you can have some very busybody patients, and they take it upon themselves to tell each other, hey, can you pull up camera 44 and camera 45, so you be an extra set of eyes. So they're not working in silos. They're backing each other up when they have busy days and they're watching 30 and 40 patients. And some of them are watching more than what they have to have 2 sets of eyes on some of the busier patients, because they can be kind of slippery little suckers and get away from you before you know.
Oh, yes, that is true. And another thing that you mentioned to me, which I thought was amazing that you're doing, I want you to share with the audience some of the things you've done to improve your monitor staff satisfaction with their overall well-being while they're working.
We encourage it. We think we have 2 sides of the room. So we have telemetry on one side, we have the monitor techs on the other side. They work 12-hour shifts. That's a long time to stare at a screen. That is a long time to sit in a chair, I think. What they did before we got here is they put the desks that raise up and down, so they're able to stand up and sit down, as they need to. We encourage them during their breaks to get out of the building. Luckily, where we are, we're kind of in a neighborhood, and we have a parking lot, a pretty big parking lot in the building, so they can get out and walk around. Now's a great time of the year to be outside walking around. We encourage them to get out and get away from the monitor, get away from the beeping and everybody else, have a little quiet time. We are looking into possibly getting one of those treadmills that slips under the desk to give them something to do. We just got all the supplies. We're just trying to find a room to put it all in. A Watson room where we're going to have a massage chair, some lavender towels, and a noisemaker. So they've got a quiet space to get away from all the hustle and bustle and spend 15 minutes just having some sort of quiet and, low stimulus environment for a bit, so they can reset.
I love it. That's amazing. I think, again, I really wanted you to share that because I thought that was so important. You're right. They're 12-hour days. Those are long days sitting in a chair, sitting at a screen. So I think that's great that you all have recognized that. So what would be the impact on your staff and patients if you didn't continuously evolve and develop your telesitter program? So you've looked at it, you're working on some things. Have you started to think about the next steps you want to take and the next things that you want to change or improve upon for the entire program?
Yes, I think you have to evolve or die. One of the things we're doing is we have a facility that is it's a community hospital, and we're talking with the administrative vice president of that facility, and he is on board with this and really likes it. So we're talking about putting cameras in every room of that facility, which opens up a world of possibilities when you talk about a community hospital that's 45 minutes to an hour away by ambulance and you have a sick patient. You're talking about being able to do consults through video. You're talking about teledoc stuff. You're talking about patient safety stuff. You're talking about, instead of having, spaces at a premium, so you can put a camera in the ceiling and still be able to get other machines. You're talking in the room and not have to worry about where am I going to put this thing on wheels, the 9-foot robot on wheels. Patient safety. It opens up a world of possibilities. So, and that's kind of where we're looking at next.
Did you see our Guardian Access devices?
I did. I just saw that.
Okay.
I was like, look at that thing.
Just saying.
Well, when you pulled it up, I was like, oh, that's a lot bigger than I thought it was, but I didn't know that was a thing. I never had seen. We are getting the ceiling ones and the drywall ones. I'm starting with those, and then the other hospital, that's what they want, is the ceiling mount ones.
Okay. I do have a few more questions from here, but I don't want to run out from the audience questions or run out of time. So I'm going to ask a few of these first, and then if we have more time left, I'll come back. Changing attitudes is an important way to change behavior. Stories help, right? So how do you share the good catch stories that I know you have?
Well, I'll tell you a good one. We had in the hospital, our folks were watching a patient who was watching for possible substance abuse, and they noticed that paraphernalia was coming in and out inside of a rabbit. And they're the ones that caught that. And I'm sorry, it was a baby doll. And they noticed that the baby doll kept getting switched out, and that the patient's behavior would change after the baby doll gets switched out. The nursing staff at the hospital actually recognized and put in and brought that to an attention and said, hey, good catch. And we try to make a big deal out of that when we have our monthly staff meetings and say, hey, you guys, this was a great catch. This is what they did. So we try to make sure we do that. We have what are called safe watches as well. I don't know if that's a countrywide thing, but it's essentially a reporting program to improve processes. Mm-hmm. And the individual that takes care of those safe watches for us, if he comes across one that is a good catch, then he lets us know, and we make sure that we make a big deal out of that.
Are you making a big deal to the hospital it took place in?
I'll be honest with you. I'm not the best at that, but I just found out the other day, and some of that's because I'm new, but Shannon is very good. She is in charge of our morale and fluff department, and she does very well at that, and they love her for it, and she's extremely good at it. But I just found out the other day we have a wow wall that we can actually take selfies with them and post it on the system wow wall. So we're going to start taking selfies and for people that have good catches and post it on the system wow wall, and then write a little blurb about it.
I love it. Yes, that's awesome. That's a great way to get that out there. Those good catches are other ways to get buy-in from your staff, from the nursing staff, from the leadership. And again, that trust, right? We're doing something. We're not just sitting here behind a camera, right? We're communicating. This isn't just a camera, right? This is more than that. Right. And your team is doing that. So that's amazing. Yes, do the wow wall. That's kind of hard to say.
Mm-hmm.
So if you could give advice on one thing that is essential to support a positive program, what would it be?
One, you got to sell yourself. You have to be your advocate. No, nobody is, you can put out pamphlets and you can send out emails and you can put out newsletters or whatever, but you have got to be the one that drives for the change, that drives for your people, and to show that you are a necessary and can't do without service. And then the other one I would say is you have got to have buy-in from your people. If you don't have buy-in from your people, and we have some really good people, if you don't have buy-in from your people, nothing you do is going to work.
Do you mean buy-in from your monitor staff?
Yes.
I never thought about that.
They're the ones that are going to make. They're the ones that are going to make or break you. You can be the worst manager in the world, but if you've got great people under you, they can make you look like you're the best thing since sliced bread. And the converse is true as well. So that's why it's really important for our folks to have buy-in and get what they do is important, that it makes a difference.
Yeah, it's not a job. It's not just a job to them. It's more than that. Right. I love it. Did you use a specific change model to encourage the change, or what specific techniques did you use to encourage change? And I think we maybe want to maybe the change of adding the maybe it's just giving an example like those interdisciplinary rounds, right? That's a big change that you had done for all the different units, correct?
It is, and we tried to,
yeah.
how can we, the biggest thing is how do we fit into somebody's, to get our service out there and get ourselves on the forefront of their minds without adding work to their day. We all know that nursing is incredibly busy, and the last thing they want is you to come in and just add something else that they got to do. Nobody wants that. So that was our driver for that. How do we,
We're there to help them.
right.
Mm-hmm.
We don't want to add to it. We want to help. And so that's how we figured out, how do we fit ourselves into what they're already doing?
Yeah, don't make me do something else, right? Don't change my process. Don't change my workflow. I don't have time for that.
If people don't like change. So if you're going to do some change, you make it as easy on them as you possibly can.
So really no model. You just decided you knew the nurses. You knew that we need to fit into what they're doing.
He's married to one.
That so helps, doesn't it?
I'm surrounded by them.
Oh my gosh, I love it. All right, I had another question. Changing attitudes. While tracking the data, how do you share program data, with staff, and how does this assist in supporting the trust behind the program? I mean, I think we kind of talked a little bit about that, but do you have anything else to add about, again, sharing those good catches? Now you're going to be using that, I think the system WOW board to build that trust. But other things that you're doing for the data?
I will be honest with you, we are just getting a hold of that. We are going to use Megan's data to help drive the purchase of, and hopefully help the cause for the implementation in every room at the community hospital. That's one thing we're going to do with it. I think before I came here, I was in the fire service, boots on the ground fire service guy. And I was a leader in the fire service. The boots on, certain people care about certain things. So a lot of managers and the higher ups and folks, they do care about the data. They care about seeing the data. They care about seeing the numbers, the fall prevention, things like that. And we want to supply those with them. The boots on the ground folks, a lot of times don't see that. They care about the anecdotal stories that you're telling, that they hear from their coworkers, or that the experiences they're having with the individual telesitters. I think that's a lot of what's driving their thought process. And the use of our service is nurse driven. So that's the other thing we try to point out to them is that this is a nurse driven service. The physician can say we want a sitter, a one-to-one or whatever, but it is also, they can do that without a physician order. So if they think it's safety is an issue, they can drive that. So we want them to have good experiences, because that's what they're sharing with each other. Not they're not sharing numbers with each other. They're sharing, well, I used that sitter the other day and they didn't, and Miss Nancy threw herself on the floor and they didn't say a word. That's the kind of stuff they're sharing. And that's what we want to make sure that they're sharing positive stuff.
That's great. Shannon, do you have anything to add to that? I feel like there's some communication going back and forth.
Clicking his cup, and I was telling him to stop because I didn't know if you could hear it.
No, I didn't. But since Shannon, what about you? For who does the interviewing? How do you hire? What skill sets do you look for your staff to have to be a good communicator, a good advocate for the program?
So this is just an entry-level position, and so we both do the interviews together, but we each take a day off during the week, so we at times interview separately. And then we get them to sign a release form to watch and shadow our techs so they can get hands-on to see what they're actually going to be doing. And if it's not a good fit for them, then we don't hire them, obviously, but we interview them, tell them, and just lay it out exactly what our expectations are, what they're going to be doing, and let them see it for themselves.
I like the job shadowing, like for a whatever. It sounds like that, a little similar before they even come on, because they might be like, no way, forget it.
Correct.
That's great. So this kind of question goes, I think maybe each of you could answer this a little bit, because what is one thing you would like our audience to take away as it relates to taking over a telesitter program? And the reason I ask this is because this happens a lot. Change management happens not just with the nurses, like for nursing staff turnover, but at leadership, even within the telesitter program. I've had multiple different leaders. What is one thing that you would tell our audience, a good takeaway?
Listen to your staff. If they're having issues, listen to them and hear them out and try to understand where they're coming from and make them feel like they're important and being heard.
Megan, just because I know it's a little different because you're looking at data, but we have a lot of customers that have just people looking at data. What would you say as you came into this program?
I would say that the numbers don't lie. Our program does follow along with other pilot studies, other telesitting studies. It falls right in line with that. And I think that if other companies are thinking about adopting this, that it's a good investment.
Jason, what would you say?
I would say you got to allow your people to have some skin in the game. One of the things that we have done is the reason we have put people on this quality initiative is because we can dictate from on high in here and tell them how we want them to do things, and you'll get that caliber work. But if you allow people to have some skin in the game and to have a choice in the direction of what they're doing, I think it seems to work a lot better.
Very true. We're getting close to the end. And so I just want to ask each one of you again, tell us any remarkable good catches. One of the good catches that happened at your hospital that you can share with the audience because of telesitting.
You took the good one about the baby doll.
That was a good one.
Well, there was one that a couple of weeks ago, he kept going in the bathroom and his girlfriend was coming in with him and they were going in the bathroom to shower, but he was coming out and falling under the walls and stuff. And so he wasn't doing anything out in front of the camera, but our staff had been watching them and could tell that his behavior had definitely changed from him going into the bathroom to coming out of the bathroom. And so they went in there and they searched him and they found some stuff.
Megan, anything you've read in the data that jumps out at you?
No, I have a personal story with the telesitters. My grandmother, who passed away this past year, but she fell and was in the hospital and mildly demented at the time. And I think that the telesitter really comforted my grandfather when he was in there with her. So I think that's also something they don't feel as lonely.
I agree. Jason, I have a few seconds.
Oscar. I mean,
Oscar.
The fact that they were watching Oscar and I would come in and check on Oscar every day. And I don't even know the man's name, but I just called him Oscar because of his hat. But just the fact that they developed this relationship and they were truly vested in Oscar left and then came back, and they were saddened that Oscar came back. And when he finally left, they were just elated that Oscar had finally found somewhere to go where he could not be trapped in this little 8x8 hospital room forever. That was pretty heartwarming.
Go ahead.
Text real quick. When the lady that we were talking about earlier that was on camera for like 10 months, she was getting released. And so our staff, it was right around, we did monitor check week around July. So they took some of the cookies and chips and stuff and made her kind of a goodie basket and took it to the hospital for her as a good luck to you, we're gonna miss you kind of thing.
Oh, that's wonderful. They really built that relationship with your patients. I see that. I just want to thank you so much for coming on to this session and sharing your amazing program with our audience. I thank you so much. It was great to meet you. I wish you nothing but more success, which I know you're going to have. So this is going to wrap it up.
Thank you.
Thank you.
Thank you, Wendy. Thanks to the team at Carilion for sharing your experience. Also, wanted to let you know we are broadcasting live out of Belmont, Michigan. Our manufacturing and corporate office is just down the road. If anyone's in the Michigan area, want to stop by, hit us up on email or chat. We'll send you the directions. A lot of excitement in the room. And really, as all that information got shared, we want to congratulate the folks at Carilion for significantly decreasing falls. That's at the heart of everything we do. We are our mission is to help people keep people safe. And so we're really proud of you and sharing in all of that. Megan, good luck on publishing the research. We hope that's publicly available. We'll be looking forward to reading that if you could share that. On to our next session. Yesterday, we spotlighted 2 of our clinical teams so that you get to know AvaSure, and this is our spotlight moment. Today, we'll keep continuing to spotlight other areas of our clinical teams, and so over to you, Mary Boyd.
Thanks so much, Dave, and greetings to our AvaSure Symposium audience. I'm Mary Boyd, Vice President of Customer Experience at AvaSure, and joining me today are some seasoned folks that are going to share some great stories about the work they do. First is Jennifer Williams, an RN, and one of our clinical program specialists, and also then Kate Hagedorn, who is one of our customer engagement representatives. So, thank you, ladies, for joining us today. Jennifer, why don't you start and tell us just a little bit about your role and how you came to this position?
Sure. So as Mary said, my name is Jennifer Williams, and I've been working at AvaSure for almost 4 years this December. And my background is in long-term care leadership, and then I also worked in acute care in clinical quality and case management. And so what brought me to the role was my interest in marrying both technology and healthcare. And so I applied to AvaSure, and I've been excited to work here ever since.
Great. Why don't you tell a little bit about what a typical day is like for you?
So a typical day is communicating with our hospitals that collaborate with us to make sure that they have successful programs. So we are essentially a clinical resource for any hospitals that own our AvaSure devices and have a program that's currently in place. And so we're available to have regular cadence of calls with these individuals or hospital teams. And we're also available via email and phone for those impromptu questions and needs.
Thanks, Jennifer. Kate, tell us what the role of customer engagement representative is all about.
Yeah, I'm Caitlin Hagedorn. Like Mary said, I've been in the role of customer engagement for a short time now, but I first started out in support, taking calls from all of our customers over the nation, which was very fun. I have climbed the ladder and I am now in customer engagement. And the role in customer engagement is really to build that cadence through a more technical side of support, and we really try to maintain a partnership with our customers, and we ensure that we have effective and efficient AvaSure programs.
Great, thank you. I should say a special thank you to Kate because she is joining us today, a special day, her birthday. So why don't we give her a little round of applause?
Thank you all. Thank you.
Thanks for making time for us today. So Jennifer, I'm going to come back to you. And, someone in your role advises hospital teams on many issues. What are the most common requests for information or assistance?
So that's a great question, Mary. Most of our common questions are about generalized things like utilization, how to improve upon utilization. A lot of our hospitals reach out in regards to best practice. What is AvaSure seeing? What are other customers doing about specific things? And then we do get a lot of inquiries about data. How can we utilize our data? How do we interpret our data? And so those are some of the main reasons that we communicate or get our customers reaching out to us.
Utilization is a very important metric. What kind of advice do you give to people that are trying to improve utilization at their facility?
So some of the key things that we discuss about utilization are ensuring that you're creating awareness across your units or across your hospitals, depending on the type of setup that you have. We also talk about a few of our best practices, like having a gatekeeper in place, which is an individual that helps to make those decisions on whether a patient should get a device or not. And so we essentially work with them because each program is individualized and has different caveats to it. We work with them to identify the best strategies for them to ensure that they're utilizing their devices to their potential within their facility.
You use the term gatekeeper. Could you go into that in a little more detail? Describe for our audience what kind of tools they use and what kind of individual fulfills that role?
Sure, absolutely. So the gatekeeper is typically fulfilled by best practice, your supervisors within your hospital. And that's because they cover a full 24 hours within the hospital and can keep an eye on utilization and the program throughout the entire day. And one of the biggest tools that they utilize is the AvaSure Administrator Panel, or the 24-hour snapshot of the dashboard, which shows you what is going on currently live with your program. So you will know, how many devices that you have in use, what types of patients that you're monitoring, whether they're high acuity or low acuity. And they can utilize this tool as a best practice to triage patients, to make sure that the ones that you're watching are the most appropriate and to ensure that you're watching the right types of patients for the right amount of time. And so having the gatekeeper in place just kind of ensures that you don't have a bunch of people making different decisions about the one thing that you want to happen, which is having all of your devices in use all of the time if possible. So the gatekeeper is there to ensure that singular and consistent decisions are made about those patients that are being monitored.
Thank you for that. So your role provides benefit to customers in many ways. Can you describe some of your best success stories?
Sure, absolutely. We have lots of success stories and lots of really successful programs. But the best success stories are when we have a hospital that's maybe struggling with utilization and they're not really sure how to improve upon that. And we can work with them with their data, working on process improvement, and get them to create that trust and awareness that Carillion was actually talking about before, to create that culture of let's think about the device first and let's utilize that first. So we've had multiple hospitals that have started off kind of struggling with utilization, and then we can help them with those strategies to get them where they need to be. And so those are some of the best success stories. Other success stories are hospitals like St. Peter's that you guys heard from yesterday that were just kind of leery about utilizing the devices for a specific use case like suicide. And we can work with them and provide them with evidence-based practice and talk to them about what other hospitals might be doing and kind of walk them through that process of implementing that new use case. And then it becomes successful and they're keeping more people safe. So those are the best kind of success stories that I like to share.
Thank you. Thank you. Any other creative use cases beside the suicide that you'd like to mention?
Yes, absolutely. So aside from suicide and fall prevention and sitter replacement, which is what our hospitals typically utilize for, we also have hospitals that utilize for workplace violence. Which we know is one of the big things in healthcare right now, not only protecting our patients, but protecting our staff members as well. So workplace violence is a great place to initiate a new use case and ensure that you're not only keeping your patients safe, but your staff safe as well.
Thanks, Jennifer. We could probably talk about this role all day long, but I'm going to give Kate a little bit of time on the stage. So your role, the customer engagement representative, is a fairly new role at AvaSure. Can you describe what the goal is and a little bit about your typical day?
Sure. So our role, like I said, is effective and efficient AvaSure programs. We are the connector of all of the stakeholders that are in the hospitals, and we ensure that they know how to follow up with us and ensure that we are continuing to help them succeed. Like I said, we are a partner with our customers, and we want to have individualized program reviews with them. We meet with them depending on the size and complexity of their program. We meet on their needs, and we schedule those meetings and meet with all the stakeholders and those decisions that they have to make.
Can you talk a little bit about that business review or operations review? What kind of information you share during those sessions or discuss?
I feel that Jennifer could maybe help me a little bit answer that one with me being so new.
Okay.
Sure. So during the business review, we kind of talk about new and exciting things that are coming to AvaSure, as well as new things that may be occurring within your hospital or organization as well, so that we can kind of stay up to date on what's going on with each other. We also review your data over the past quarter, and we can look at some trends clinically and identify some of those pain points that you may be having, or even recognize some of the areas that you're performing well in. And then we also make sure that we have appropriate contacts at each site, let anybody know if there's anybody new at the sites or with AvaSure. We also talk about some of the new features and some of the new technology that AvaSure might have. And then we kind of work together asking any questions or responding to any questions that any of that senior leadership may have in regards to the program, and kind of helping them keep that practice in place of ensuring that we're supporting the program from the top down.
Great, great. Well, we've heard some great catch stories today, and I wonder if either of you would like to share a great catch story.
Sure. One of our more recent great catch stories that we've had was at a site where a patient was a little more vocal and needed a lot more attention in terms of going out into the hallway, trying to get the attention of the staff that were obviously needing to do other things at the time. They put the camera in the room, connected them with their monitor tech, eased her communication to where she felt as though she was more safe and at peace. And we provided them that communication that was very seamless and connected her with the right resources.
Great one. Jennifer, would you like to share a story?
Sure. So some of my favorite great catch stories are ones that aren't necessarily connected to safety, because I think sometimes we think, well, I mean, not that all things are safety, but not necessarily connected to like saving a fall or something to that effect. Some of my best great catch stories are when they're watching them for something and then something completely out of the blue occurs and the monitor staff catch that. So one that comes to mind is a patient who was being watched for fall prevention, and the monitor staff just happened to see her ingest a powder-like substance. And the patient actually coded, and due to the quick response of the monitor staff and being able to bring the clinical staff into the room immediately, they were actually able to work on that patient and save that patient. So I always just like to point out that this isn't necessarily just about preventing falls or replacing our sitters. Sometimes we're actually impacting patients' lives as well.
Thank you for sharing. So one area we didn't talk a lot about was data. What kind of data do we collect for our customers and share during, individual calls or operations reviews?
Sure, absolutely. So we have a platform called ORNA, Online Reporting of Nursing Analytics, and it provides a wide array of data metrics for your hospital to utilize, not only for recognition and recognizing where you're doing well in your program, but also to look at for process improvement and make sure that you're identifying those pain points that you have and can work on those. So some of the main metrics that we look at are utilization. So how often are your devices in use? And we calculate that in a percentage over the month. And then we also let you know how many total patients you've monitored, how often your monitor staff are talking to your patients. We provide stat alarm response times. We also provide, how long are you watching your patients? And some of the really important metrics, your discharge metrics, which help you identify how well your clinical staff are performing. So how often are you discharging patients and what are you discharging them for? And can you better improve the way that you're monitoring your patients and for how long to ensure that you're capturing that full population of patients that you would like to impact?
One of the other things we hadn't yet discussed is where in the customer journey you join the team and interact directly with customers. So do you each want to describe that, please?
Sure, that's a great question. For clinical program specialists, we're actually introduced right at the end of the implementation. So we are introduced by the clinical implementation specialist that works with you throughout your implementation. They introduce us on that last call connection, and then 2 weeks later we provide your first education and review your administrator panel with you. And then we typically meet on a pretty regular cadence every 2 weeks, for a couple of weeks, then every month for 4 to 6 months. And then we meet with sites quarterly. And then that cadence can be changed and increased or decreased depending on your program needs.
Very detailed and very flexible as well. Thanks, Jennifer. Kate, do you want to talk about your role?
And then for our role, we can you repeat your question?
Oh, when you're introduced in what part of the customer
Yes,
journey?
we assist post go live. Thank you for repeating the question. I drew a blank for 1 second. Yeah, we assist as soon as the site goes live. So as soon as you become a customer, we are there to assist as a partner long term. For as long as you have us in your hospital, we are there to assist you with whatever needs you have. And that also includes the ticket history on the maintenance of the devices. That's more of the customer engagement role. We do the more technical ticket history. We track that data and we use that in our program reviews as well.
Well, great. Seems that we're pushing up against the end of our time, but I want to thank you both for sharing your knowledge and in really impressing our audience with all it is that we do to support our customers. Thank you.
Thank you.
Absolutely.
Thank you so much.
Thanks, Mary. Thanks, Jennifer. Thanks, Kate. So nice to spotlight some of what we do. And I wanted to, before the next panel discussion, to talk a little bit about this. You may have noticed that I'm holding an award. At AvaSure, we help people keep people safe. And we take great pride in that. And at the same time, we've recently been recognized for reducing the cost of care. And what I'm holding is the Class Research Award that we received. It's been an amazing year here at AvaSure, where we are, we've been recognized in the emerging technology category for Class. Class hosted an award session about a month ago. 42 companies were surveyed, graded, scored, if you will, by 16 CIO luminaries within the industry against the quadruple aim of healthcare. And AvaSure ranked #1 in the area of reducing the cost of care. And so we want to thank all of you for helping us achieve these significant results that gave us this great recognition, and it's an honor to share that with all of our customers and with our team at AvaSure. Now on to our next session for the day, centralized monitoring. Optimizing labor across an entire health system is our next topic, and so please help me welcome moderator Sarah Quiring, AvaSure Clinical Program Specialist. Come on up, Sarah.
Thank you so much, Dave. Like you mentioned, my name is Sarah Quiring. I'm a clinical program specialist here at AvaSure, and I'm very excited to be monitoring our centralized monitoring panel. So to get things started, I would love to have our panelists introduce themselves. So Mark, can we start with you? Tell me a little bit about your role and your Hub and Spoke program.
Sure. Yeah, my name is Mark Quirin. I'm the regional manager for virtual monitoring at Hub 1 for Trinity Health. We're located at the Loyola University Health Center, our system in the Chicago area. We opened in August of 2020. We've got the capacity to monitor up to 240 cameras across the Trinity system. And we've got a mix of hospitals that are new to virtual monitoring and some that previously had their own centralized hub in their facility.
Thank you so much, Mark. Catherine, can you tell us a little bit about your role and your Hub and Spoke program?
Sure. My name's Catherine Mitchell. I'm the nurse manager of the Central Monitoring Unit and Video Monitoring Unit at Baptist Medical Center as a part of Baptist Health System in Jacksonville, Florida. We currently have 120 cameras for use throughout the system, including a couple of freestanding emergency departments. And we also began one of our facilities in August of 2020 due to the COVID pandemic. And at that time, we started with 16 cameras, and it was so successful that we grew to 120 cameras for use throughout our facilities. We have several hospitals in Jacksonville, Florida, and surrounding areas.
Yeah, thank you so much. And Kalia?
Hi, yes, I'm one of the assistant nurse managers for our care department at Cox Health in Springfield, Missouri, and we manage our telesitter program here. We currently only have 30 cameras, but we are looking to expand that because our program has been so successful. We currently monitor patients on our telesitter program at up to 5 different locations right now.
Great. Well, thank you all so much for being here. It's great to talk with you. So Catherine, to start things off, can you tell me a little bit about the implementation process for your Hub and Spoke system? How did you go about getting the initial buy-in, and who are the stakeholders that you needed to engage with?
Sure. So thankfully, we had an administrator at one of our hospitals, Baptist South, that was really passionate about this program. And how it came about for us is that she was rounding on a COVID floor in August of 2020, or the spring of 2020, and noticed a sitter in her N95 and full gear, mask and everything, gloves, gown, in a room. And she noticed that patient throughout the shift. So she had an idea to begin a program that developed telesitting, because we did not have that here at Baptist. And so she looked into it and researched it and got the administrators for our health system involved. She got parties from every one of our campuses. We currently have cameras at 6 different facilities with, we're sending cameras to another facility in about 2 weeks. So she got together with executive leadership and our financial department, nursing leaders, case management leaders, social work, all sorts of different parties involved. And she created this initiative to buy the 16 cameras and buy the technology. And then that program grew in about the next year to include nurses and staff at various hospitals throughout our system, to where we now are off-site in a centralized location monitoring the cameras. So this was an effort by Elizabeth Gunn, one of the administrators. She's a nurse. She's one of our nursing directors, executive leadership, and it was a program really. She initiated the program with AvaSure's assistance with multiple people throughout the facility. There have probably been about 100 different team members involved in the implementation of AvaSure at our facilities.
Wow, that's a lot of people to get this up and running. And Mark, I know that you were there at really the start of Trinity's Hub and Spoke program. So can you speak a little bit about that for you as well?
Yeah, I was kind of brought in about 2 weeks before our first go live. So a lot of the pre-work was already kind of done and considerations made, but I know a lot of the things that we really looked at. One of the things was the location of the hub. I mean, we're watching all 4 time zones. So where do you want to sit this hub? And one of the considerations we had was, is there going to be a workforce available to us as we go through the hiring process? And so that's why we ended up in the Chicago area, a lot of with the population of people in the area we're in. Other things are obviously some of the data that's out there on the cost of sitters, the FTEs of sitters spent at each hospital, along with their falls rates and falls with injury. So I think those are some three key pieces of data. And then you kind of go into, how many cameras per hospital. And we looked at, the size of the hospital, their fall rates and their sitter costs, and kind of came up with some calculations on what we think they should have as we went live.
Yeah, I'm so glad you brought up finances. Can you talk a little bit about how you do the finances and budgeting for a hub and spoke?
Yeah, so the way we do it here at Trinity is each spoke that has cameras, they pay for a certain percentage of their cameras, 60%. So those finances are what support our mission. They support my staff, any upgrades, whatever it might be. So it's kind of if you will say, like a flat budget for us in regards to income, because every hospital is paying for that number of cameras regardless of how many they use. So my goal then is to make sure that our FTEs are at a level to make sure we're managing that need. If all of our hospitals can get to 60%, or we're showing that above 60 is where we need to be, maybe creep up to 70 or 80%, the finances are going to change for every hospital. But at that point, we're able to show the value of the camera, and so it's got worthwhile increase in their charge.
Yeah, thank you. Kalia or Catherine, anything to add for how that works in your organization?
We do something very similar to Mark, where that hospital, that outlying hospital, has their cameras, they're allotted to them, and then that's what they're budgeted for. When we first initiated the program, the first year we initiated it was in November of 2017. I was not part of the program at that time. So Tabby, I have her here with me because she was helping with part of that when we initiated it. But our first year we saved $1.3 million because we were able to reduce 30 FTEs of sitter needs. And a lot of those outlying hospitals, they don't have as much of a sitter reserve to pull those employees to watch those rooms when there's not cameras available to do that. So it's worked really well for us on our end in both budget and getting buy-in from staff, because they know that they're going to have their staff that can remain on the floor to take care of their patients instead of getting pulled to sit in these rooms and watch these patients.
Wow, that's amazing. I do have a follow-up question for you, actually.
Yes.
When you're looking at tracking like your sitter rates and your fall rates across different organizations, you may use different systems or different metrics. Did you struggle to align those metrics so you could track your progress, or how did that process work for you?
We use the same systems for all of our locations. We're all on the same fall regulations and things like that. So they are all tracked the same. That is not something that I was part of originally, so I can't speak to how that occurred at that time, but I know we have currently, we look at our ORNA data, we look at any incident report that comes in. If it was a fall while it was on the telesitter, we're able to look into the interventions that were completed by the telesitter. And sometimes, all of those verbal interventions were done, the stat alarms were activated, but unfortunately the staff just weren't able to get to that patient fast enough because the patient is so fast sometimes, but it really has reduced our falls overall.
Oh, that's fantastic to hear. And Catherine, I know that we've talked in the past about tracking data. Can you talk a little bit about how you do that across your organization?
Yes, we have an opportunity for improvement in our organization for tracking data across the system. One of the issues that we've had is that we seem to operate very differently between hospitals. So Baptist Nassau might operate differently than Baptist Beaches or Baptist South. So we are still working through our process of tracking data, but I sit on a number of committees to assist with the data collection. One of our risk managers is a data analyst, and what we use to normally track our falls, which is one of the most important patient populations or reasons that we use AvaSures for falls, as I'm sure you all can agree. We have a system falls committee that I sit on that we use our STARS reporting system, our incident reporting system, to track falls and falls with injury. And so we are closely every month looking at our falls. We just rolled out our program system-wide in January, and that's when I took this position. So I'm relatively new, but we are now looking at our data from January through October of 2021 of falls and falls with injury versus our January through October data of 22 to make sure that we've seen a reduction in falls. So we are constantly looking at our core measures and our data points to make sure, through our incident reporting, to make sure that we are reducing the risk of reducing falls while also reducing the use of sitters. We did not have a great tracking system for sitters for our system before AvaSure, so we are still working through figuring out how to track sitters. We have some opportunities for our tracking methods.
Yeah, thank you so much for sharing. Now, one of the really important parts of a hub and spoke is sharing data across your organization. Mark, can you talk a little bit about how you share data, and then how do you get buy-in for change from that data?
Sure, yeah. One of the things we do is we have a hub spoke meeting once a month. That's where I really present some of the ORNA data as a hub itself, but then I also break down by hospital what their data is going to be as well. Send that out to them. So I know that's one of the challenges is getting the data. So instead of having them look it up, I will send it to them so it's at their fingertips as best I can. And that's where we can really kind of look at things like what's our stat alarm response time, what's our utilization, all those kind of things that make the system effective. I think I have some of the same challenges that other people do as well in regards to collecting the data that we don't automatically get, like falls rates from 22 different hospitals, just to kind of tabulate it all together is one of the challenges we continue to work through. But we talk about that at that hub spoke meeting as well. From there, we can determine what processes are working, what processes aren't working. Not only do we use ORNA, we also use the dashboard that's available and really break down some things that we can look at our side as the hub. Because I think a lot of the ORNA data is kind of the accountability on the hospitals and how are we doing for them. But it's also when I look at the dashboard and break down some of the information there, I can kind of look at my own staff and say, how are we doing our job well? And I want to make sure that the other hospitals understand that I am holding my staff accountable, and these are the challenges that we work on as well.
Yeah, can you talk, I heard you mention holding your staff accountable. How do you communicate some of the challenges, between nurse perception and what actually happens at the monitor station? How do you kind of build buy-in for the program while also, there's things that come up. How do you address that?
Right. Yeah. A lot of the challenges, a lot of the staff we hire are entry level. So just trying to help them understand healthcare in general. I'm the only nurse in the department, so I come from at least a little bit of experience of what it's like to be on the floor. So I try to kind of give them some perspective of what it's like on the other side. I heard in an earlier panel today about how they send their DMAs over to the main hospital to kind of get that perspective and vice versa. I love that idea. I think I want to try to capitalize on that a little bit more than we do. Just to help with that buy-in, because I think that's the biggest challenge is the perspective that each side has. The hospital's perspective of what they think we do and vice versa. So kind of bridging that gap is kind of a goal that I think we want to kind of move towards.
Yeah, and Kalia and Catherine, I see you nodding along. Kalia, can you talk about that process for you as well?
So it's been very much continual education between both groups. We have the telesitters that do verbal intervention. They'll call the nurses station sometimes if they need to talk with the nurse or to tell the nurse that this patient looks like they may be wanting to get up soon, but they're not necessarily to that point where they need to do a stat alarm. But we've had some issues in the past where they weren't utilizing like the verbal intervention part of it. And so, when we run those reports to track their interventions and if they're intervening appropriately, we don't have any data to support that if they're not utilizing those verbal interventions and their stat alarms. So we've had to talk a lot about, even if you're just calling the desk, you need to verbally intervene into the room and say, I'll call and get your nurse. So we've had to work on that quite a bit just on our own staff's accountability and how they intervene with their patients. But then we also have had the nursing side that, they may come in the room and wave at the camera and think that the monitor tech can see them just because the camera's in the room. So we've had to kind of work on that belief that just because they're not saying something back to you or they're not responding to you when you're talking to them, that they're always seeing you. So we've had to do so much education about, they're watching up to 10 patients at a time. If they're not clicked on that room, they can't hear you. If they're zoomed in on a certain area of the patient that they are monitoring, they are not going to be able to see you in front of the camera. So we've offered to bring some people into the telesitter room and just kind of observe what they see. So they're able to help bring that back to their units as well. And help educate the rest of their floors when issues like this come up as well. It is something that we've struggled with more recently. Now that we've kind of gotten a little bit out of COVID, we're kind of going back to a new state of normalcy. So we have struggled with it a little bit more. So it's something that as a department, we're also working on with our unit-based council as a project house-wide to help provide more education to the rest of the organization on what the monitor tech can see, can't see, what challenges they have, and then to also bridge the gaps of what challenges nursing is having with these telemonitors as well. So it is something that is a continual work in process, I feel like.
Yeah, and Catherine, how about for you?
Yeah, I would echo both of your suggestions and concerns and ideas. We are located about a mile from our nearest hospital. So we are in a business building that is owned by our health system. And one thing that I'm really passionate about is keeping the safety monitor techs. That's what we call them here, safety monitor technicians. Ours is known as the VMU, Video Monitoring Unit. I'm really passionate about keeping them connected to patients and keeping them connected to family members and team members in the hospital, because already, we've been here since January, already there's some feelings of disconnect. Like, where do I fit in? I'm not a part of the hospital staff anymore. I don't work for one hospital, I work for the health system, and our health system is huge. I think we have about, probably not as big as yours, Mark, but we have about 15,000 team members with our health system. We're the biggest health system in Northeast Florida. So I'm constantly trying to keep them connected. One thing that I've loved doing is I try to have a nurse manager or an A&M round through my department every week from one of our outside facilities, one of our spokes. And that has been great in building relationship, because as I tell the techs a lot, like if you have a relationship with the team member on the other side of the camera at the facility, they're going to be a lot more likely to pick up the phone and call when there's an issue rather than, fire off an email or tell on someone. So I'm always about trying to build face-to-face relationship with the aid of technology, of course, because that's what we're here doing. We're monitoring patients through the use of technology. But I too, I go present at all of the nursing orientations at our different facilities, our different spokes, so I can stay connected to the bedside staff myself. And then I try to go meet with someone in a facility, one of our spokes, at least once a week. So I'm trying to maintain face-to-face contact with them, talk to them in person about AvaSure. I round with the hospital staff and make sure that they don't have any questions about AvaSure, see if they have any concerns, anything that they feel like we can do better on our end in the VMU. So it's a constant effort in maintaining that face-to-face contact with the hospital staff. I don't ever want to lose sight of that. And that we've been quick to lose sight of it here off-site. So that's been an important part of our program and the success of our program.
Yeah, so it sounds like a little bit of education and a marketing piece for you as well. So I do have a question about how you hire, train, and in this day and age, retain your monitor staff. Kalia, I think I heard you mention that you have a unit-based council.
Yes.
Could you talk a little bit about that?
So throughout our hospital, we have like a house-wide partnership council that all of nursing staff is able to be on, and there's different process improvement ideas and things of that nature that they go over every meeting to help improve our organization. So as a subset of that housewide partnership council, we then have each unit has their own unit partnership council that any staff member can be on. So our unit in particular, we have RNs from all the different clusters. We have ICU, ED, med-surg, maternal child, and then we also have nurse assistants and our patient safety assistants, which are our telesitters. And also another role called a unit assistant. So we have every position that is on our unit-based council. So we can really bounce ideas off of all these different positions and try to make process improvements that, maybe one position sees that this, is an issue that we need to work on resolving, as another position may not have realized that that was an area that we needed to make improvements in. So we're able to work on these initiatives in unit-based council and then put them into a bigger project that we can bring to housewide and see if it's an actual change that we can make within our organization.
Yeah, thank you so much. And could you talk a little bit about your hiring process for your monitor staff? What are like qualifications that you look for?
So we actually, we have our patient safety assistant position, which is our sitter position, and they sit in rooms with our patients. And so we actually hire everybody as a patient safety assistant first. And then we train them for approximately 30 days, look at their performance, see how they're doing, see if they're interested in the telemonitoring role. And if they are interested in that, then we do an additional training in that room to see how they perform in that role as well. We used to wait till they were out of their 90-day probationary period before training them in that monitoring role. And we did find that we were having more problems staffing that monitoring position because, maybe somebody really liked just enjoying sitting in the room and didn't want to take that opportunity to learn the monitor role. So we have moved to a shorter period before we start training them in that, and that has worked much better for us in our program. But we want to make sure that they, have some sort of, technology ability. We do have a lot of patient safety assistants that apply that just are not interested in technology and are very concerned about, watching multiple patients on a camera. And so those people, they choose not to do that, and that's okay. But we want to make sure that it's something that they're capable of, and we're setting them up for success when we start to train them in that role.
Yeah, exactly. Mark, can you talk about that process for your organization?
Yeah, we've actually had a little bit of a challenge with the hiring retention piece for a variety of reasons. But what we're trying to do for retention is we're trying to be creative with our scheduling. Right now, all of our people are 12-hour shifts, which, it's a long time to sit in a cubicle. So we're trying to get flexible with what that looks like. We also try to get them as many possible breaks, scheduled and unscheduled, as they can, so they can get a break away from it. So it doesn't feel like it's like, wow, this is a long, 12 hours in front of the camera. So trying to maintain that retention. For the hiring, we identified some process challenges just within our system that we're working through. But we also try to look at what opportunities they have to move forward, right? So if I'm a sitter or a virtual monitor assistant, where do I go from here? So we're offering, some of these people have come in with no healthcare experience at all. They've seen a CNA at work and they say, I want to do that. So we have a CNA program right here at our facility that they can kind of go to. And I've had a few people kind of grow and go into that. So for a hiring perspective, that's a nice opportunity, but for a retention opportunity, it kind of takes away, but it helps support the facility in a different way. So we appreciate those kind of things as well. Our VMAs aren't required to have a CNA certification, but we are working towards trying to find a VMA, a virtual monitoring assistant / CNA job description, so we can share them with the hospital we're attached to. So maybe one day they work as a CNA and the next day they might work over here in virtual monitoring. That's a great tool for somebody who wants that variety. We really honestly expected to get, when we went live, a lot of CNAs that had been doing it a long time and their bodies just couldn't take it anymore. we thought they'd want to come over and do this kind of work because they've got the knowledge, they understand patients and things like that. It just didn't work out the way we thought. So we take a lot of entry-level people and try to grow them from the different side.
Thank you. And Catherine, how about for you?
Yeah, so our system is set up a little bit different than what you guys are saying about your systems, but we all of our video monitor techs are, we call them ACPs, associate care providers, CNA, PCT. All of our video monitor techs are current ACPs or CNAs. They hold a CNA license in the state of Florida, and they all have hospital experience. So most of them have had anywhere, I think my youngest CNA, the least amount of experience is 3 years. And then I have some CNAs that are the monitor techs that have 20 years of experience. So we have a wealth of experience at the bedside in our department, which is, I think it's part of what made it so successful here. These team members come in already knowing what a Foley catheter is and an IV and a Quentin and what it means to be intubated. We have just something that's kind of funny. It sounds silly, but we have sit to stand desk. And that's been really beneficial for our team members who are sitting at the screens for 12 hours so they can sit or stand. We have exercise equipment in our department. So we have several stationary bikes. We have an elliptical that they can pull into their station to use an elliptical while they're watching their patients. And we actually have a waiting, don't hate me, we actually have a waiting list to get into our department. So the staff, I think, see this as a great environment to work in. We are in a wonderful building with great parking. We are not in a hospital facility, so we do Fun Friday, one Friday of the month, where we pick a theme and we have a potluck, and that builds great employee morale. We have had a pajama party in our department. Sounds silly. People love it. We do karaoke. We've had a hot chocolate bar. Because we don't see patients or physicians or other staff members, we are pretty much isolated in our central monitoring unit. We have 120 team members. We average about 32 a shift. So we have some opportunities that the hospital staff don't have, and I think that creates a lot of team morale and a lot of team member satisfaction. So our hiring process is you must have your CNA license, and then you apply, and we give usually about 9 shifts of training before we release a team member to work on their own. So we work 12s. They normally work 3 12s of orientation with an experienced monitor tech, and then they are able to take their own assignments after that. Sarah, something else I wanted to mention that's been really successful for our department, I think it's unique, is that we have a lead safety monitor tech that is up. So they are like an up charge nurse. They never have an assignment, ever. They've had an assignment of 1 or 2 patients since January, one time. So we have a great resource that is available for the technicians to relieve them for breaks and help them be a second set of eyes for patient. I think that's part of what's made our program so successful, is that extra lead monitor tech that is able to assist the department.
Yeah, thank you so much for sharing, Catherine. Your hub sounds like a lot of fun. Mark, I know that you also have a lead as well. Can you talk a little bit about what their workflow is and what type of responsibilities they have?
Sure. Yeah. So we do have leads. They don't take patient assignments, and I think that's just invaluable, just as a resource or relief, whatever it might be. They're the ones that do the majority of communication with the hospitals, whether it's trying to track down a phone number, kind of figure out what's going on, camera problems, things like that. They do all the admissions and all the discharges, so the VMAs can pay attention to the existing patients along the way. And they're constantly rounding on staff as well. And I think that's one of the big things we try to do, is just make sure it's not just keeping the VMA engaged. It's, hey, what's in your way? Everything going okay today? Is your patient assignment adequate enough? We have the VMAs that are watching, 10 sleeping patients, and the next station they might have a VMA watching like 5 or 6 really busy stations. Maybe that team lead can balance that out so they both can manage their assignments a little bit better. And then they also do some accountability things. They will observe patients while a VMA is watching to say, are they, activating that stat alarm appropriately? Are they doing a verbal before they stat alarm? Things like that, to make sure we're keeping some accountability and some reinforcement to the VMAs as well.
Yeah, thank you so much for sharing. You know, one of the questions I always like to ask is, what have you learned and what would you like to share for maybe a hospital who's just getting started with a hub and spoke program? And Kalia, I'm going to start with you.
Like I said, I wasn't here when they first started, but after talking with some people that were here when the hub and spoke was initiated, one thing that we may have done differently is maybe we didn't involve enough of the right people during that time. So we didn't involve like security, you know, not all of the nursing units were involved in looking at the program before we initiated it. And maybe that was something that we could have done differently at that time, because we do have security that is involved in a lot of our patient monitoring areas. We are located, our program is located in our largest facility. So they are located on a floor that actually has med-surg patients on it at that time. So we have, we don't have a lead, but we have like a tele T4, and they go and round on some of the PSAs that are actually sitting in rooms, which has worked well for us. But I think that with implementing the program, we could have done just a few things differently, and it has worked out well since we've kind of made arrangements to get more people involved and having them involved in our decision-making going forward.
Yeah, thank you. Catherine, how about you? Lessons learned.
Lessons learned. Wow, there's a lot of them. One thing that's been really beneficial to me that I just started this month, actually last week, was a steering committee. So someone encouraged me to start a steering committee. So it's a you know, we're 8 months into our program here, so we're starting it a little bit later down the road, just a few months. But that I think is going to be really beneficial for the implementation of our policies and our procedures, is to have a steering committee. Because I work on it every day, you know, 10 and 12 hours a day. So I'm not able to see some things that maybe people from the outside the steering committee is able to see. And I think for me, just really increasing the communication between the hospital staff members and our department. We have opportunities to communicate better and to really reach out more and reach across all facets of the patient's care to partner with them to keep the patient safe, since that's all our #1 goal. And something that I would like to see in the future is better partnership with our behavioral health department. We have a children's hospital that we watch that's been, we've had some disconnects with our children's hospital and our behavioral health areas. So there is some team members that are working with me that work directly in behavioral health, and we're starting to work more closely together to target behavioral health patients and help them more, help keep them safe and monitor them better and more closely. And I think I wish we had started that from the beginning. I wish we had started our partnership with behavioral health from the beginning, because at first I think we were really focused on falls and on keeping patients safe through AvaSure that were fall risk, which is wonderful. That's one huge part of what we do. But I really think that we missed some opportunities to partner with behavioral health team members throughout the process of initiating AvaSure. We're getting into that more now, but I think we could have avoided some issues that we've had throughout our program by partnering with them earlier on in the process.
Yeah, Catherine, I do have a follow-up question for you. What does that partnership with behavioral health look like?
So we try to involve we have mental health evaluators in our facilities that are evaluating patients when they come in with a mental health issue or Baker Acts. We also monitor low to moderate risk Baker Acts. That might be unique for AvaSure users. I'm not sure if it is, but it might be. We do not monitor high risk for suicide, but any low to moderate risk behavioral health patients can be monitored by AvaSure if they're appropriate, meet the other criteria. So we partner with the mental health evaluators. Those are mainly in the EDs, the psychiatrists that are seeing patients, and then just the mental health team, caseworkers and nurses that are part of the behavioral health team. Here at Baptist, we have units that are dedicated solely to behavioral health in both our pediatric and our adult populations, and we are starting to partner with them more and more about how we can watch their patients better and what we can do to assist them and keep staff safe and the patient safe. And one of our opportunities for improvement is that we are in the process of having more behavioral health education for our monitor techs. We weren't really sure at the beginning, I think, what kind of education to provide for the monitor techs upon their hire and throughout the year and as a yearly competency. And we're really partnering with our behavioral health educators throughout our system to roll out more behavioral health education. A big population that we watch here is eating disorder patients. And so there are a lot of monitor techs that don't have experience with watching pediatric eating disorder patients. And so we're trying to partner with anyone from the nutrition team for the pediatric population to the caseworker to the mental health evaluator to increase our training and awareness of uniquely behavioral health issues with patients.
Yeah, thank you so much for sharing. It sounds like you've really done a good job with an interdisciplinary approach. Mark, for you, can you share some lessons that you've learned and maybe some things that you wish you had known going forward?
Yeah, I think number one is absolutely build strong relationships with your spokes, not just between the clinical staff at the bedside and the VMA, but also with that hospital leadership. The hospitals that we have a better leadership relationship with just outperform everybody else with utilization, use of the camera, problem solving, process improvement. It just is really valuable as one thing. Helping your staff understand that delicate balance between being watching for patient safety and being big brother. We're not here to evaluate nursing job or a CNA job. We're here to keep patients safe. And I know that's been a little bit of a challenge for some of my VMAs, like, well, they're not hourly rounding and they want to write incident reports and that. I'm like, just slow down. That's our primary focus is going to be patient safety. But there sometimes is that delicate balance between at what point do we call and say, nobody has seen this patient in a while, can somebody go in and see them? So that's that difficulty of that delicate balance. And also, I think, get involved in whether it's systems or individual hospital falls teams early. They forget we're here sometimes, and they're talking about falls, and they're talking about what could have prevented this, and they never mention AvaSure. So getting involved in those along the way or early on to really help them bring, oh yeah, wait, we've got this great technology we're not utilizing yet. You know, we hear about the fall. We're on a morning meeting with our local hospital every day, and we hear about a fall, and we're constantly asking, why were they not on a monitor? What happened? Why couldn't we get that? And we've got 21 other hospitals we have to kind of work with on that too. So getting involved early is key.
Yeah, thank you so much for sharing. I think as a hub leader, you're really in a unique position to build relationships across your organization to improve patient safety. So that being said, I would love to hear a great catch that you've had to keep your patients safe. And Kalia, do you have anything that comes to mind?
So our monitor techs, they are entry-level staff. So they are not necessarily trained on how to monitor a patient's health condition, but we have had one recently where they just noticed that the patient's breathing changed. And it wasn't even a big change. You know, they just noticed, oh, you know, they were breathing a little more frequently than they are now. And the patient's respiratory rate had decreased quite a bit. So, you know, their respiratory rate had been in like the low 20s, 20 to 24, and then it decreased to like 10. And so they called and just alerted the staff, and the staff were able to go in there and call a rapid response on the patient. And then it's not something that they're necessarily even trained to necessarily watch for, because they're there for patient safety. They're watching lines, tubes, drains. So it really was a good catch that thankfully this patient was on a monitor to prevent something terrible from happening.
Yeah, that's a wonderful story. Catherine, how about for you?
We have great catches all the time. One of mine that stands out is we had a patient who brought in drugs. We watch for substance abuse. Some of our patients, we watch for substance abuse issues. And one of the patients had brought in a pillow full of drugs. I think it was Percocet and Xanax pills. And they had cut a hole in their pillow and brought in their pillow, as a lot of patients do, covered in a pillowcase. And when the staff was watching the patient at night, so the lights were out and it was dark in the room, but they could see the patient, of course, they noticed the patient, they caught the patient slipping his hand into his pillow underneath his head, removing these bottles or these pills, and then trying to ingest them. And so some of our night shift staff made a great catch of alerting the nurse immediately that the patient seemed to be doing something with their pillow, and they went in and searched the room, and the patient had ingested a couple of their Percocet, a couple of their Xanax pills. So we had a great catch from the staff being especially on top of what could be seen as like a normal patient sleeping, moving around in their sleep a little bit, adjusting their pillow, but actually he was taking pills out of his pillow. So.
Wow. Yeah, things you didn't even expect or probably weren't beginning to monitor for. Mark, how about for your organization?
Sure. Yeah, I am still amazed at how many people and visitors sneak in things to their loved ones in the hospital. It just blows my mind how many things we catch and the creativity that they use to do that. But actually, one of my favorite stories is really more about, we had a patient who was super anxious and he was constantly calling the nurses into the room. I need a drink of water. Can you move my pillow? Can you do this? Really anxious in the hospital. So my VMA just started having a conversation with this person. The nurses are getting really frustrated with him. And as my VMA just started talking to him casually, building relationship, she talked to him the whole night. And the patient eventually stopped using the call light, stopped calling those nurses in, stopped getting out of bed, and really helped those two nurses that were dealing with that patient take care of their other patients as well. And I love that story because it's not just about the patients we watch. It's about the patients that we can watch that frees up staff to do better care for the other patients in that department. So it's, just bringing somebody's anxiety level down where they're not constantly asking nurses things really made a big impact on those nurses. In fact, it was our local hospital. They were so thankful they actually walked over to our department, which is at the opposite end of a huge campus, just to find this VMA and thank her for the night that, she made a difference on.
Oh, that's a wonderful story. I love that the nurses acknowledged your VMA as well. That's awesome to hear. Well, we're getting close to the top of our time, but since we've been talking about great catches, I'd love to hear how you're sharing those across your organization. Obviously, you all have great catches. How do you really push forward your VMA and reward the good work that they're doing? And Catherine, can you talk about that?
Yeah, so something, two ways I get messages out about great catches. I send out a monthly PowerPoint report every month to our facility site leads. We call them our AvaSure champions or site leads. So I send out a PowerPoint, and that's really numbers. That's not really much about the good catches, but that is our numbers for utilization, our number of verbal interventions, stat alarm response time. We award a unit each month, like the winner of the AvaSure monthly contest for great use of AvaSure. But every week I try to send out an email with, I send it to our team, the VMU team, as well as all members of the hospital staff that partner with our team. So this email goes out to about 100 people with a good catch. And I highlight the patient, what happened with the patient and what the great catch was, and then recognize the team member as well. We also have something that we use at our health system called just a kudos. And you can go on our intranet and place a kudos for a team member that's done a great job or gone above and beyond. And I try to do those regularly every week or two to one of our team members that's had a good catch. So constantly just trying to recognize the team members for the great work they're doing via email and announcing it in staff meetings and announcing it at orientation. And any chance I get in front of our facilities, I try to recognize at least one staff member in a good catch. Nurses love a good story, so everyone's always all about them.
Yes, a story can really, it changes people's mind, which I think is so important. Kalia, can you talk a little bit about how you reward your staff and share the good work that they're doing?
So we send out a weekly outlook every week where we highlight all of the recognition for the staff across our department and that to our entire department. We also make a PowerPoint similar, but we do it in staff meeting every month, and we recognize everybody that's been recognized in staff meeting. We also write a lot of just individualized thank you cards to our staff, just so it is more personable from their leader as well. And then we work a lot with the managers on the other units. If there's a good catch that's occurred on their unit, they make sure that that is brought up in their staff meetings as well with the telesitter and the floor that it occurred on. We also have a Facebook page that's designated for our staff, and we also post it on there so everybody can see what a great job they've done.
Lovely. Well, thank you all so much. We're at the top of our time, but Clea, it was lovely meeting you. Catherine and Mark, always great talking with you. Thanks for sharing all this information with us. Take care, everyone.
Thank you.
Thank you, Sarah, and great job to all of our panelists. Thank you so much for sharing all of that valuable experience with all of us. You know, prior I mentioned this class research award. This was part of a conference about a month ago, and what really resonated was one of the CEOs mentioned that for us as technology providers, and I'm reading this, when it comes to making a difference and change in healthcare, it's 10% of it is about the technology, and 90% of it is about the people. It's about the change management. It's about the teams. It's about the difference that everyone's making working together. And with that in mind, I'm thinking about our next session with the spotlight. All of our different spotlights have been pointing to our teams working with all of the provider teams. And so I wanted to, as we move towards our clinical implementation specialists, point that out. This is our last spotlight session. And so I'm going to turn it over to you, Mary Boyd.
Thanks, Dave. And greetings to our AvaSure Symposium audience. I'm pleased to be joined today by two of our registered nurses who serve in the capacity of clinical implementation specialist. And so first is Sarah Peterson. And why don't you tell us a little bit about your work experience and how you came to work at AvaSure?
Thank you, Mary. Hi, everyone. So yes, my name is Sarah Peterson, and I am a clinical implementation specialist. So what I do is help to prepare our customers clinically in, workflow, policy, staffing, hiring. And as far as a little background on me, I graduated back in '03 as a new nurse. I got some years of experience on med-surg and PCU units. Went into travel nursing, traveled for 9 years, and got a lot of experience in different hospitals throughout the country. So basically, some of the hospitals are actually utilizing our devices at this point, so that's kind of a neat fact. But then I was getting a little tired of the bedside grind, so I was looking for something different and came across LinkedIn for a clinical educator with AvaSure. So I applied and got the job, and that's how I came to be here with AvaSure. I did a clinical educator role for 4 years, so I was actually out on the sites doing the education and training to bring the programs live. And then just this year in January, I transitioned into this clinical implementation role.
Great. And next to her is Kim McClure. Why don't you tell us a little bit about your work history?
Thank you, Mary. Hi, everyone. My name is Kimberly McClure. Again, I'm a clinical implementation specialist. I've been a nurse for about 10 years now. I've worked in a variety of roles similar to Sarah. I started off in cardiac, worked a little bit of general surgery, did a stint in the OR while I was getting my master's degree, and then I did some Epic implementation for Go Live at our facility, and then finally ended up in the telehealth realm doing telemedicine for our organization. During that time, I actually implemented our program for AvaSure at my facility. Shortly after that, I came and joined the AvaSure team, and I have been here for 3 years now.
So the title of your position certainly implies that you facilitate implementation services, but how can you describe the process that we go through to help customers go from that purchasing decision to bringing their program to serve patients? Sarah, you want to take that one?
Sure. So once a customer has decided to go forward with our program, it comes to the implementation team. So there's a group of us involved in that, and that would be a program manager. and then the clinical implementation specialist, as well as some technical support as well. So what we do is we have kind of weekly call agendas. So we start with a kickoff where we kind of overview everything in the plan, how we're going to bring the policies into practice, getting the technical details worked out. And then each week we have a specific agenda of items that we'll cover to make sure that we're setting up those customers for success.
So I've heard that this process is typically 8 to 10 weeks, and that we often get the question, why does it take so long? So you've spoken to some of the detail, but how do you respond to customers who at first question the process that we follow?
For me as well.
Yeah, you can take it.
Okay. Yeah, as far as the process goes, there is a lot involved in getting your program up and running. So not just, creation of your policy and workflows, you're initially establishing goals and outcomes that you're looking for, but additionally hiring. And we've seen lately that that can be a really big barrier. So we want to make sure that you're set up for success. So part of that is having a full staff for your monitor station so that when you do go live, you're able to provide 24/7, 365 monitoring, because the staff, when they hear that this program is coming, are often very excited. They're looking forward to the benefits that they're going to see from that. So not having that staffing in place can be damaging to your program once you make it available and then there's no one to staff it. That can be a problem.
Okay, thanks, Sarah. Kim, can you describe the key customer roles that typically participate in the implementation meetings?
So for our implementation meetings, we typically like to have a manager or director who's going to be overseeing the program at the facility, as well as other managers throughout the clinical team to help provide input. We've seen other sites bring in some frontline staff members, whether that is nurses or like PCTs or CNAs, to help with the process. For my facility specifically, we engaged our Nursing Informatics Council, brought them in for their feedback on workflows. If you are looking at like integration, then you want to definitely include your like EMR team to help get their input and their build process as well. There's also, we provide e-learning modules, so you want to include an LMS contact and maybe even some clinical educators as well to help with the education portion of it.
And on the technical side, who from the IT organization participates?
So from the technical aspect, you'll want to include someone from your network team, infrastructure, even desktop, someone who can help manage the program from that aspect and get the necessary people involved. You'll need to have someone for like server builds, as well as other technical aspects too.
So you've described a very multidisciplinary approach. Can you perhaps talk about the role of champion and why it's so important to have one person overseeing the entire implementation that has the true accountability?
Yeah, so a champion or lead of the program is really important because they're the ones that are going to be like the driving factor of your program. They're going to be coordinating everything from your facility standpoint, making sure that you're hitting your deadlines and that all necessary personnel are at the table for the discussion.
So you've talked about developing workflows and a master policy. Sarah, can you describe what is included in that policy that guides the program and how we go about assisting customers in their unique situation?
Sure, yeah. So in that policy, we like to see and we need to see the criteria spelled out. So you're going to see who should be included in monitoring. We'd like to keep that broad. There are many, many reasons that you can use this monitoring with patients, as well as exclusion criteria, so those patients that would not be appropriate to be placed on device. And we like to see that as a much more narrow criteria. So your inclusion exclusion criteria, we also like to see written into that policy a required trial. What we see sometimes is some hesitancy from staff to adopt new technology, new processes. So that can help to encourage them or, cause them to start using it initially. Sometimes we'll see staff, they're used to having that bedside sitter. It's nice to have that person at bedside. So they're hesitant to give this a try. But with that required trial, they start to learn how it can actually truly benefit them and learn some of the benefits that we don't even normally expect sometimes. So we like to see that required trial built in there. And then, of course, it's going to spell out the various roles and responsibilities. So the primary nurse, what their expectations are in the process, the monitor staff themselves and what their expectations are. We want to see a gatekeeper role built into that. That's a very important part of the program. They're integral to guiding utilization, making sure the proper patients are on device, and then helping to monitor a wait list if you get to that point where you're utilizing all your devices, which is what we hope to see. As well as some information on what will you do in downtime situations. So whether it's planned or unplanned, what's the call escalation process look like? So if the monitor staff reach out to the primary caregiver and aren't able to get a hold of them, who do they go to next? So those are some of the things that we like to see in that policy.
Great. It's a all-inclusive and kind of universal overview of what the program is and how it's supposed to be run. So thank you. So Kim, it's not always easy to facilitate the implementation. What might be one of your tougher challenges that you could share with us?
Yeah, I think probably one of the tougher challenges is starting off a project with not everyone at the table or everyone on the same page. It's really, as I mentioned, it's really important to have all parties present for these calls and to make sure that everything gets implemented in a timely manner and nothing gets missed throughout the process. So I think that's probably one of our biggest challenges is starting off meetings, just not having the appropriate personnel on each of these calls.
Yeah, and I liked how you described earlier the importance of health informatics and some things that you wouldn't necessarily think about implementing technology in a patient safety system. Sarah, any tough challenges that you would like to share?
I think to kind of piggyback off of that, because we are doing this remotely, it's sometimes difficult to stay focused and make that connection over a Teams call. So we encourage video that kind of helps to build that relationship and keep people focused. I know for myself, sometimes I may not turn on the video if I'm not actively involved in a call, but what happens then is you're probably multitasking and being distracted, and then you're missing out on crucial information that you could use.
So I've heard a good policy, a multidisciplinary approach, active participation. Any other important features that you think signal a successful go-live?
Good communication, a plan for good communication. So one of the items we'll come up against as we're planning a go-live is the nurses. Do they carry a mobile phone or some sort of communication device? So we really encourage, if there isn't something in place, that something is planned. So whether it be, some sites will order mobile phones that they'll deploy right along with the devices if they're not able to roll something out system-wide, or getting some kind of a walkie-talkie or Vocera type communication device. So that is a very key part of the program, communication all around. So I would say that's something that comes up that we would like to recommend.
Kimberly, you talked a little bit about integration. Could you expand on that and the types of integrations that we've been doing and how helpful they are to the process?
Yeah. So we do have multiple different types of integrations. The one that we've been working mostly on with some of my sites is EMR integration. So building an order into your EMR and having that flow into our software. So it'll pull in the admission criteria for the monitor staff so they don't have to do a manual admission process. We also have some outbound integration into your call lights, and we are working on some other outbound capabilities as new projects with our sites as well.
Great, adds to the efficiency of the program. So one of the things that we like to talk about at AvaSure are great catches. So I'm going to ask each of you to share at least one great catch story. And Sarah, we'll start with you.
Sure. Yeah, I have a few, but let me start with this one. So recently one of my sites had implemented with, in their pediatric units, and one of the patient populations they see a lot of are eating disorder patients. And so it was new for them, so it was a learning process for both the monitor staff and the staff on the units to kind of trust the monitor staff to monitor those patients. But one of the patients was pinching their abdomen, trying to increase, burning calories, and the monitor staff was able to catch that and report it to the nursing staff.
Great, good story. Kimberly?
Yeah. So one of my recent facilities is a rehab hospital, and they had a patient that had a lap belt on, and the monitor staff had noticed that that lap belt had slid down to the patient's ankles, and the patient was attempting to get up. So the monitor staff had set off the stat alarm to notify the nursing staff. They were able to respond and get that patient back into their chair before they had a fall at that time.
Great. Both great examples and the variety of great catches that we see in people using the AvaSure system. So we're getting close to the end of our time together. Is there anything that I didn't ask about that you wanted to share with the audience this afternoon?
Yeah, so another important thing for the program is going to be education as well. We do provide, as I mentioned earlier, e-learning modules for the program, so you guys will have access to those for the whole duration, pre and post go live. But we also provide best practice guidelines as far as our training schedule. So we do send an educator out on site for go live and education support, provide multiple different types of classes for both your monitor staff and your nursing staff. So we do provide a well-rounded education program for you to ensure the success of your program.
Thank you for sharing that. That's an important feature. And Sarah and Kimberly, I want to thank you very much for sharing your knowledge with the audience, and appreciate your time.
Thank you.
Thank you so much, Mary, Kimberly, and Sarah, for that spotlight. And Kimberly and Sarah are nurses who have years of expertise helping multiple sites go live and support that. So thank you for expertise. I'm Lizbeth Votruba. I'm the Chief Clinical Officer at AvaSure. And I'm slightly sad that we're almost to the end of our second day with one more session to go. I just love this opportunity to provide a forum for nurse leaders across the country to share best practices with each other. And nursing leadership is so critical to the success of telesitter or telenurse implementations. And to that end, AvaSure has been strongly committed to the American Organization for Nursing Leadership for a long time. And both with philanthropy, and I also am able to donate my time as a volunteer to be on the AONL Foundation board for many years. So in 2020, we were thrilled when we were honored by AONL Foundation Friend of the Year Award in 2022. And it's just been a thrilling year. And wanted to mention that at the end of our virtual symposium this year, looking forward to next year. And now I'm very excited to introduce the final Fireside chat that we're going to have with our own CEO, Adam McMullin, and also with Gerry Lewis, who is the Chief Information Officer for U.S. Radiology Specialist. And prior to his current role, he was most recently the Senior Vice President and Chief Information Officer at Ascension Health, which is the largest nonprofit health system in the United States. And as we heard a little bit about yesterday, they have a very robust telesitter program with a hub and spoke model. And Kim Beckett, the manager of the hub at the Michigan hub, was so excited to share that yesterday was their 4th year, she coined a new phrase, hubiversary. So we love our partnership with Ascension Health, and I'm very excited to hear this conversation about how technology plays a role in the future of healthcare.
Great. Well, I guess it's up to us to bring it home. Gerry, are you out there? Can you hear us? Oh, we can almost hear you. Can we hear Gerry?
Can you hear me?
Yeah, we can hear you now. Perfect.
Perfect.
Hey, I'm thrilled to wrap it up here with a fireside with Gerry Lewis, and as Elizabeth mentioned, he's currently the CIO for U.S. Radiology, previously CIO and an EVP for Ascension, where he led and presided over creating the end-to-end IT infrastructure to support everything from patient to provider. So excited for this discussion. But I got to tell you, Gerry, I was reading right here. I was reading down your bio, and there's a lot here. Not only all the work at Ascension, but also as an advisor to Salesforce, Athena Health, Google, Microsoft, AT&T, also working with the Scottsdale Institute. And I love this, the work with NPower, helping our vets and young adults from underserved areas get their own start in the digital world and digital career. So, and then I've had an opportunity to spend a fair amount of time with Gerry. I love this, given our current geopolitical situation. He started his career in the CIA. I think they went and found you right on campus, didn't they?
They did, yeah.
So what a unique background, and looking forward to our discussion. And but before we dive into it, Gerry, I know you have your own personal experience with AvaSure, and I think it highlights just the meaningful nature of what we all do and the things we're privileged to help enable and moments we enable within healthcare. So I thought, first off, maybe I just turn it over to you to talk about your own story.
Sure, absolutely. So, healthcare is personal to everybody. And my father-in-law, before he passed away, he was in a rural hospital in Kerrville, Texas, Peterson Memorial Hospital, great place. And he spent a week and a half there. And I walk into the room, and that's the first thing I saw was AvaSure monitoring device. And it was interesting because the room was very small. It had the bed, it had a recliner, but really didn't have much room for family and for the nurses. And so for him, and he had Alzheimer's, so he would wake up every night and he would be very disoriented. And so, they had restrained him, and, he would wake up, and, the device would alert the nursing station. So we got on really good terms with especially the nighttime nurses. But for him, it really helped him, towards the end of his life, with the right amount of really quality coverage and quality care that he needed. And we as a family were very satisfied with that, with his encounter, but also that really at the end of the day, it's technology that aids and allows us to have more coverage to improve those outcomes. And so, you see it, and then when you get impacted personally with it, you're very much appreciative of the opportunities that we have to leverage technology to improve the experiences and to improve outcomes, clinical outcomes at the end of the day.
That's great. I'm glad, obviously condolences to your father-in-law, but glad that, we had a solution there to help at that time.
Yeah, thank you.
Hey, Gerry, I thought, just to start also personally, maybe if you just share a little bit about how did you get into healthcare, right? You started outside of healthcare, you got into healthcare, the mission matters, and just kind of your connection with the mission.
Sure, absolutely. So I before I worked for Ascension, I worked for Dell. And at that point in time, the president of the Seton facilities was close with Michael Dell, and they thought that Dell could do technology a little bit better than they could do. And so I got the opportunity. Supposedly it was only a 2-year engagement for me, and 21 years later, I'm still here. So I started there, and the whole role of technology is how do we enable, how do we provide capabilities that support care, really at the end of the day. And so that meant a lot to me, both professionally and personally. And so I never left. I never left.
I got into healthcare after being outside of healthcare myself, and it allowed me to find a sixth gear. I got to do some things that were intellectually interesting, but to be able to connect to the ways that you can impact care for a patient and a care team and enable transformed processes and better outcomes is just it's humbling and inspiring at the same time. A lot of this group, Gerry, would like to know a little bit more about how do you drive change in a health system? How do you get transformation initiatives across the goal line? That's what a lot of what we've talked about in the common themes in over the conference here have been about how do we change the current state, make it better, do it more efficiently, improve outcomes. As you looked at probably the myriad different transformation initiatives you oversaw, how did the ball get rolling, get started, and what are some of the best practices you saw?
Yeah, so I think it really revolves around 3 things. I think the first thing that you have to validate is, does this differentiate the experience, both the patient experience as well as the clinical experience? I think as healthcare information technology, we've set a fairly low bar, so we have lots of opportunities, I think, to improve that experience. So number one, does it help us look at the end-to-end, both clinical as well as patient experience? 2, does it help us improve the value of the services that we provide? Can we provide better services going forward? And can we be more efficient in terms of how we deploy those services across all of our sites of care? And then 3, just given the environment that we have, is there an opportunity to also start to bend the cost curve? So as we get more efficient, as we get, create the opportunities for better services, can we actually then create the opportunity to bend that cost curve, which is a challenge, quite frankly. And so we look at, all those 3 things, quite frankly, in terms of those lens. And if they can meet 2 or 3 of those, that's a significant opportunity for us to take those next steps in terms of trying to understand what that means in terms of the value, the investment, the resources, how do we operationalize it? And so those are the things that we look at as we start to evaluate, do these technologies or do these capabilities have value? And really at the end of the day, and we've talked about this quite a bit, it's the partnership with our clinicians. I try to live this every day, that we're clinically led, but we're technically enabled. And again, if that partnership's not there, it's very difficult. And that's why it's so important to have the relationships and to understand the strategies and the challenges that we have to deal with from a clinical point of view, because my job is to take those friction points out to improve that process end to end and to enable that with the appropriate capabilities that actually improve the patient as well as the clinical experience.
You know, I like that when you said, you know, clinically led, technically enabled. You know, we often are engaging with clinical teams first, and then there comes a point as where initiatives being kicked off or conceptualized that they bring in their IT counterparts. That's not always a smooth process. Right. They don't always speak in the same language. A lot of the folks at this conference come with more of a clinical background. Sure. Can you give them any advice or insight as they're thinking about expanding programs, you know, transforming care models? Maybe they're looking at now launching into virtual nursing from sitting, into how they work and engage their technology counterparts?
Yeah, I think number one, and the previous panel talked about communication. It's really understanding the strategies and how you want to grow and how you want to integrate and innovate differently. And to me, at the end of the day, it's about an ecosystem, you know, and that ecosystem's number one, the experience that you want to provide. But it's enabled by infrastructure, it's enabled by platforms, it's enabled by that integration. And so I think, you know, making sure that your technology partners understand your vision, your strategy, where your challenges are. I know right now for at least US radiology, when we want to schedule patients, it's a 12-step process. My job now working with my clinical and operational partners is how do I take those friction points, and how do I take friction out of that process to enable it for our patients, but also to look at it from a clinical point of view, and how do we ensure that we have the right information so that we can effectively schedule a patient for an exam. And so it's having that relationship at the end of the day with your partners across the clinical and operational spectrum, so that you understand each other's strategies. And then also the priorities of which that this is ranking for you from a clinical perspective, because as we all know, there's never a boring day in healthcare. And so how do you manage the priorities effectively so that you're getting the most value from the investments that you're making?
Got it. You know, one of the other things we run up against, you know, working with the technology teams is, you know, they're constrained. Right? Yeah. It's just the capacity, right? Everyone's busy. There's never a boring day. The stakes are high. Are there any things that could be done as initiatives are formulated to get ahead of some of the capacity constraints? You know, oftentimes it might be integrating with the EMR. It might be standing up some of the infrastructure that's necessary. Right. Any best practices you see with streamlining that so that you know, we can get the work done as efficiently as possible?
Yeah, I think a few things, and you know, we've had a few conversations, but you know, as we start to change the approach from really one that's providing services, the end-to-end services, I think that takes a few steps away, if you will, from either having to create a virtual server or to rack another server. You know, I think understanding that end-to-end, what it means end-to-end. In terms of your vision of what this platform or these services should provide, and how that plays in the larger, more holistic experience that you want to provide, I think is really important. And I go back and say, listen, my job's not really a technology job; it's a relationship job, and so the relationships are hugely important. And again, you know, depending upon how technology is governed at your particular area, it's having that understanding in terms of the governance and the value part, because especially now, you know, as we have a lot of the financial concerns with some of the headwinds that we're all facing, it's being able to articulate the value and articulate what it will take in terms of the lift to actually create and enable this service. All those become really important in terms of how we start to break down these solutions so that we can implement them really at scale at the end of the day.
Yeah, you know, the ROI, we're seeing, you know, a much even greater focus on the financial ROI. You know, you've got, as you're well aware, volumes, you know, still not recovered to the pre-pandemic levels. We've seen what's happened in costs, and that's costs across the board. It's drug costs. We know what's happening on the labor side. So I know we as a company are working to do our best job to partner to really get clear on the financial aspects of that value proposition.
Yes, I used to have a boss that would say, "Listen, if I can invest $1 today and get 3 back in the next 2 weeks, I'm in." And so, how do you present those types of value?
Too.
Yeah, that's right. That's right.
Given the way that the market's been going, you know, that'd be let's go find that deal.
That's right.
Hey, Gerry, you know, we're focused every day on innovating around virtual care, right? We want to be laser focused as a company on sitting. That's where we started. It's at the heart. You know, we're working on sort of the AI enablement of that to even further improve outcomes and you know, the value proposition. We're launching into virtual nursing. We've also got a couple of areas where we've got some physician use. And so that's where we're focused to have that common infrastructure in acute care. As you were sitting on the Ascension side and thought about virtual care, I'd be interested in just your thoughts on where it was going, what the priorities were, kind of how you saw the future of virtual care happening, particularly as it relates in the acute care environment.
Yeah. I think number one, from my point of view, it's how do you provide the coverage that for these particular services. One, I think to be the other part of it, and we talked about this, is just the cost. You know, is there an opportunity for this solution to improve my clinical outcomes, improve the experience for my patients and my clinicians, but also can I leverage this to start to bend the cost curve? And you know, again, those are the 3 things I'll go back to. Again, if we can differentiate an experience, and we know we have challenges on coverage today, you know, with our clinicians, and if you can extend that in a way that actually improves the experience for our patients, but also for our clinicians, and leveraging the bending the cost curve and reducing those costs, because you know, again, it's about those particular fundamentals, I think, that really allow us to move virtual care forward. And it's not something that's going to go away. I think in every facet of healthcare, there will be a level of virtual care, whether it's primary care, acute care, post-acute. I think we're now into that environment. And I think as you look at this holistically, what does that holistic workflow look like? And what does it look like end to end? And I think there are times in healthcare that we look at it more vertically versus horizontally. And this is really part of that horizontal workflow. And how are you looking at, again, taking out friction points and improving those processes and the experiences as you look at this much more holistically? And I think we owe that to our staff. We owe that to our patients to be really thoughtful about how we look at virtual care and how it enables and how it improves and how we look at the outcomes in just a different way, because you know, it's part of I think the fundamental building blocks of going forward in terms of how we provide that care across the country.
As you think back on your history of where we are in healthcare and some of the highly acute financial pressures right now, do you think we're at, as we think about adopting some of the new technologies to truly transform how work's done, right, rather than you know, potentially do the same process and just try and do it faster, or maybe in some cases with electronic documentation, it wasn't always faster, it was a little bit the opposite. Do you think, you know, and by the way, healthcare, another thing, right, it's the only industry as it gets bigger is actually at negative efficiency,
That's right.
You know, and uses more labor with scale, which is, you know, the opposite to how other industries work. They tend to apply more technology to operate more efficiently. Where do you think we are? Are we at some sort of potentially catalyzing event where, hey, we've got some proven principles here around things like virtual care, process automation, maybe even some of the AI and work that we push farther into these areas, and we truly kind of reconceptualized how work's done and break it, you know, to stop doing maybe some of the old ways faster?
Yeah, I think we're at an inflection point because of the skilled care labor shortages that we have, and the amount of time it's going to. I don't even think we'll ever get past the existing nursing shortage that we have. I think we have other subspecialty shortages too. So I think we're at an inflection point that we have to look at the problem very differently, both in terms of how we apply labor, and what types of labor are applied, how we apply technology. But I think it's most fundamental that we look at this much more holistically as we move forward. And, I think we will continue to have, challenges with, making sure that we've got enough bandwidth in the types of labor that we need from, an acute care perspective, especially, that we're going to have to get past that, and we're going to have to use other enabling technologies, other workflows to actually start to, I think, it really improve the overall outcomes and the experiences and the models that we have, the new models that we'll have to create because of that. And I think it'll be process, it'll be technology, it'll be, people as well. So I think looking at that, in a very different way is something that we have to do, because the fundamentals, especially in healthcare, are going to continue to be challenged. I just don't see that ending anytime soon.
Well, I know when you were sitting from the Ascension vantage point, you thought a lot about what the future could look like. And we may have some write-in questions here from coming in from those that are watching this virtually. But to give a little time for those to get up to me, I can't let you out of this without sort of stepping back and saying, what do you think are some of the other things that are really promising and exciting on the horizon that you're able and willing to share?
Yeah, I think, as we think about, virtual technology will be something that we will have to manage. And I think people are actually welcoming that technology coming forward. As we leverage, you mentioned artificial intelligence or machine learning, how do we automate some of those processes that should be automated? And I think part of it for healthcare is how do we start to remove some of the variability that we have, both in terms of our workflow and our technology, so that we can leverage more efficiencies. And I think part of it, to me, is creating an overall ecosystem so that we can share information more effectively, because it's too complex and it's too challenging to share information across, across sites of care. So taking a step back to, are there opportunities for us to simplify? Are there opportunities for us to leverage modern tools and technology so that we can enhance and take advantage of new capabilities that are out there? I think are things that we have to look at, and creating this end-to-end tech ecosystem that leverages, I'd say enhanced clinical processes and integration, so that we're not overly burdening our clinical staff, both from a cognitive as well as from a burnout perspective. I think we've got to do that, because, at this point in time, if we don't, I think we're going to be challenged to ensure that we can take care of the people we need to take care of in our communities.
You've been so consistent in talking about the relationships and the focus on clinically led. Given that our audience is almost entirely clinical, it might be helpful for them to hear, and I got this as a question, you can see right here. It might be helpful for them to hear just some of the evolution on the types of roles that were in your organization that brought in or infused more clinical insight, and the types of roles that, if you're a clinician and you're out and you're working on a transformative project that you might want to reach into your own IT department, engage with, to be able to start formulating these types of transformative projects?
Yeah, I think a couple things. Number one, I would say the role of a clinical informaticist and how we leverage data to provide more insight is crucial. I think we put a lot of, we overly burden our clinicians with data. We've got to start putting that data in context, so you have enough clinical information to make those next best clinical decisions without seeing rows and rows and rows of data. So I think that's huge. And I think the other part of it that we push our teams is you have to have empathy. You have to understand how the technology is being utilized. And if it's not being utilized, why isn't it being utilized? And so, again, having that empathy and understanding how the technology is aiding, or in many cases, actually taking away from the clinical experience is something that we've got to constantly tune. And then I think working collectively to understand, so that we're maximizing the processes, as you talked about earlier, and not just automating things that we've done for 50 years, which, I would say in the first evolution of EMRs is essentially what we've done. Taking a step back and looking at this much more holistically and understanding how we should optimize the process and then leverage the technology to enable that process is really important. I think too many times we talk about technology first, and then we wrap clinical process around it, and then you have really frustrated clinicians and frustrated patients, and that's just we've got to move away from that.
I love it, and I love the comment you also made on the rounding. So probably another great best practice there to our clinical audience that if you're working on something, maybe you go out and in an HR friendly way, grab your IT counterpart and get them on the unit with you. When I've had the opportunity to visit many customers and go around and watch the training and watch the work being delivered, and some of these answers they really jump out at you when you're there. You see both opportunities and you see things that almost break your heart in terms of what people are working around, and why things break that you can't see unless you're there personally. We had one situation where a communication loop had broke because someone moved one of the endpoints and just moved it, and we couldn't have figured that out till we were there. And so I think that's a great best practice, just walking in your counterpart's shoes. I can see you nodding.
Absolutely. And you know what? And there are times we create such brittle workflows that don't account for the real world. And now I'm doing this on the radiology side, and the way we've set up some of these workflows, if you don't do 1 through 10 and you stop in the middle and take care of a patient or answer a question, if you don't start at 1 again, then you lose all your work. That's crazy. So again, being thoughtful about how you design and working with your partners to design an effective process that you can enable the technologies to support is really crucial. And the more we do that, the more we create the relationships, the more we create the trust, the more we actually start to break these really complex problems down and consistently iterate. I think one of the things that healthcare, I used to be 6'4", and on a good day I'm 5'9". We like to go after these big bang projects that we expect everything to be perfect, versus taking this really set of complex problems, breaking them down and starting with 20% and iterating, constantly until we collectively feel that we've solved the problem effectively to meet your clinical needs. And that's just a mind shift change, I think, collectively. But that goes back to the partnership as well.
I love it. As we're kind of getting a little closer to the end here, the clinically led, technology enabled, that partnership. I hope this session is sort of maybe emboldened or inspired some of our clinical folks to go out and realize like everyone's working on the same mission here, right?
Sure.
We want to serve more patients and deliver better outcomes, and do that in a way that is financially prudent, and everyone's on the same team. So your clinical teams working with the technology teams to sort of redesign the work and transform care is where it's at. Hey, Gerry, one last thing maybe before we wrap. Is there any story that jumps out to you? And I'll ask the question slowly, give you a little time to think. That was just touching, and you may have seen some of these other sessions. They end with sort of a great catch. But is there anything that you saw in healthcare that just kind of helped you like fan the flames of like your passion for the mission, that might be useful? I'm putting you on the spot to share with our audience.
Yeah, I mean, in working so long with Ascension, healthcare is a right, and I don't know. I worked ED rooms at Friday and Saturdays. I've seen lots of things that our clinicians go through, and I think really at the end of the day, it's the kindness when you're at your most vulnerable that I've seen our clinicians really provide to families and patients themselves, that kind of give you goosebumps and make you want to do this all over again, but figure out how you do it better so you can do it 1,000 times, more. And that's why I never left, because I felt it, and you want to make things better. Then you got what actually make things better when you leave than when they got there. And I think we have the opportunity to do that. And I think, again, it's a credit to everyone who's in the audience that does that day in and day out. It's my job and our job to make sure that we can support you more effectively than we have, and continue to ramp that up so that we can care for more people in our communities.
I love it. That's a great way to wrap it up. I can't thank you enough for taking some time to share with this group. Leave us and then with some goosebumps. I've got a colleague that calls them passion bumps, as you kind of fan the flames there. And but that's why we do what we do and get up every morning. Hey, Gerry, thanks so much. Really appreciate it.
Well, thank you all for what you do as well.
Thanks, Gerry. Thanks, Adam. Folks, that wraps up our last panel session. That wraps up our last AvaSure session. So want to acknowledge all the speakers, all the panelists, all the presenters, all the great information and sharing. And hopefully you're asking, fantastic, what's next? So I do want to point out, next month we will have a webinar with our partners, EQUM, EQUUM. You'll find them on our partner page. They're our staffing partner. So if you're looking for additional patient tech monitor resources, tune into that webinar where we're talking about technology and staffing and the future and where that's all going and how to solve everyone's critical needs there. Once again, an email will be sent out next week with links to all the recordings. You can go back and replay today's, or if you missed yesterday's, join in on those. Everybody loves a good gift card raffle, so please fill out the survey at the end of today's symposium. We're going to raffle. We're going to pick folks out of a hat, and lucky winners will receive a gift card. But most importantly, we need the feedback. We need information from you in terms of the topics, the content, how we improve. Not only the content, but also how we engage with you going down into the future. And then last but not least, please visit the additional resources we've got out on our website, in our YouTube channel. Look for upcoming events on our events page. And just want to extend a wholehearted thank you once again for everyone for your time. We know you're all busy. We appreciate it. Have a great day.